Good morning, respected doctors. My name is Nishant. I'm based at Mumbai head office Alkem. It's my great pleasure to welcome you all to this ENT workshop at Jaipur, arranged by Team Clavam Alkem Magna. I would like to extend an especially warm welcome to all of you who travel for to be with us today. Doctor, Alkem Magna has always supported the cause of otolaryngology in India. Conducting this ENT workshop is one such endeavor in the same direction. It is a thoughtful program built to cover all aspects of functional endoscopic sinus surgery from molecule level to surgery and its complications. So doctors, without any further delay, let's begin the workshop with inaugural lighting of the lamp and Ganesh mantra. I would like to request following dignitary to please come step forward for lighting of the lamp. May I please request respected Dr. Satish Jain sir, Dr. Dhrubo Roy sir, also from senior leadership of Alkem, Dr. Mr. Ranjan Ghosh, Mr. Omkar Debashish to please come forward for lamp lighting.
आरोग्यं धनसम्पदा शुभं कुरुत्वं कल्याणं.
May I please request Dr. Rajan Bhargav also to please come forward.
शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोस्तुते दीपज्योतिर्नमोस्तुते दीपज्योतिर्जनः दीपज्योतिर्परं दीपज्योतिर्जनः दीपे पापं सन्ध्यादीपनमोस्तुते दीपं ब्रह्मरूपस्य ज्योतिषां प्रभुराज्ञ दीपं ब्रह्मरूपस्य ज्योतिषां प्रभुराज्ञ देहि पुत्रांश स्वच्छामि ते.
So now the time to honor our mentor, the brain behind this entire ENT workshop, the dynamic personality in otolaryngology in India. We are extremely happy to have with us respected Dr. Satish Jain sir. His extraordinary personality does not need any introduction at all. A noble man with a great character. So ladies and gentlemen, I request you all to huge round of applause for Dr. Satish Jain sir. I welcome and I request Mr. Omkar Debashish to please come and welcome Dr. Satish Jain sir.
Good morning, all. First of all, welcome to the Pink City for this workshop. And I know you all are busy guys, all practitioners, and coming all the way for this basic workshop on sinus surgery. It's a real pleasure to have you all. Thank you once again. And big thanks to the team Alkem Magna for once again showing their commitment to the academic endeavors. Thank you so much to the entire team for organizing this entire setup. Thank you so much. This course, can you start? Actually is designed on a very basic topic, chronic rhinosinusitis. We all know as the time is changing, if you look at the past in otolaryngology, ear surgeries were on top, still on top. And the place for the rhinology surgery was very, very low or very small, I can say. At the time is changing, more and more understanding of the rhinologic diseases have come forward. And now more and more rhinologic surgeries are on place as compared to otologic surgeries. And we all know the big reason behind this. The ear and nose problems are together. They have same pathophysiologic mechanisms and one promotes another like that. More and more treatment of the rhinologic disorders have brought the otologic disorders on the downtrend. And this workshop is basically our endeavor to share our experience on this topic of chronic rhinosinusitis. We all know this subject went on a big research in 70s when Messer-Klinger and Stemberger started their work on endoscopy and found something revolutionary, that all sinuses drain through the ostia into the nasal cavity, not by the gravitational drainage. And that burst in a big way and endoscopic surgery was popularized. But what we have seen over the couple of years, that time the Stemberger was one of the most popular person in the American circuit who introduced this concept of sinus surgery, and people started everywhere following him and done thousands of sinus surgery that time. Over a period of year, what we realized, the recurrences. His concept was you open up the sinuses, establish the ventilation and drainage, and the inflammatory disease of the sinuses will revert back to normal. And it happened. But over the period of the time, the disease again came back. In spite of having all sinus ostium open, in spite of having mucociliary activity normal, in spite of that, the disease came back. And so a lot of research work started on this, on understanding this disease. This is not a mechanical disease, purely medical disease. Surgery is the answer. I will discuss fine nuances of what exactly this disease is. So aim of this workshop is to share our experience of what has been done on this subject in the last 3 decades. We have reviewed more than 4,000 publications. I will share with you. I will give to the team LCAM, and anybody wants to have those publications, more than 4,000 publications on this subject, right from the molecular level to surgery and complication, including everything, what has been done as a research work on this subject until now. Besides that, my personal interaction to some of the stalwarts, particularly Professor Stemberger, Professor Richard Harvey, Professor Sethi, couple of times, hours and hours of discussion on understanding this disease and sinus surgery and so many other things. And our own experience of having done more than now 10,000 cases of sinus surgery at our setup in our span of last 20 years. So this is all the endeavor to share our work, our understanding on this subject with you all to improve, to optimize the treatment of this disease, chronic rhinosinusitis. As it looks like from the name, like an infective disorder. This is not infection. This is pure multifactorial inflammatory disease. It has been now very well understood. So this is going to be an interactive session. This workshop is designed in such a way that we can cover all the aspects. Mostly in the workshop, we discuss only surgical aspects. But what we believe, without understanding this disease at the molecular level, our surgical understanding and the overall results cannot be better. So we'll start our course with basic understanding of this disease, decision-making, comorbidities, how to deal with that, difficult situations, when to operate, when not to operate. The operative details will be discussed in the afternoon when we'll show live surgery. And that will be again from the basics, from the basic cases to the most advanced lobsters and other cases tomorrow. And then finally end with the complications and their management. So the basic and the most important part and the core part of this workshop is understanding this disease at the molecular level. As we have understood, this is an inflammatory disease. Anything, all the drivers which are driving the inflammation, we need to know so that we can define more and more new targets to control this disease. This is a medical disease. Co-treatment is medical. Surgery is not a co-treatment. And in times to come, as I'm going to share with you, again, the medical treatment is going to be the co-treatment with hardly any scope of sinus disease in the future, 10, 15 years down the line. This has come out with the recent research work. So to start with the Stamberger's work, what I said, initial treatment for this, what Stamberger and Messerschmitt proposed was to open up the sinus ostium. You establish the ventilation and drainage and expect the inflammatory disease to revert back to normal. It is a mucosal disease and the mucosa reverts back to normal once the ventilation and drainage is established. It still works. This concept still works. But the problem is, this is not the disease which can be cleared by the mechanical treatment. And many a times, what surgeons believe, see, this presentation is going to be very, very clinical once this understanding starts at the molecular level. And there are certain myths which invites a lot of medical legal problems also in this, management of this disease. So the biggest myth is sinus surgery is the ultimate cure of this patient or the disease. Believe me, this is a medical disease once again, and the co-treatment is medical, not the surgical one. Yes. Yeah. And actually the treatment starts after the surgery most of the time. This is not a single disease like any other disease. This is a sort of syndrome where we need to look at various aspects which modifies the course of the disease at different levels. Every patient has a different underlying pathophysiological mechanism which need to be understood now. That is what the current understanding of precision medicine, because there are so many variables in the diagnosis, in the pathophysiology of this disease, and every particular patient needs a particular, precise treatment. So, traditionally, what we have been doing, why we are gathered here, to improve the outcome of this treatment of chronic rhinosinusitis. When it comes to surgery, to improve the outcome of surgical exercise. So, traditionally, what Messerschmitt and Stamberger proposed was this one. And now, that concept still stands. But now, since the disease comes back, it has been understood, the disease has been understood at the molecular level, the drivers of inflammation have been understood, and it has been proposed that at most of the steps of this disease progression, it is a steroid which works maximum at every level. And the role of this surgery has now changed dramatically. It's not that you remove the disease and get back to the work. You remove the disease and you need to do something to prevent further inflammation, ongoing inflammation, to control that ongoing inflammation. And then this disease gives you, once you open up all sinuses, establish the ventilation and drainage, it gives you access for the topicals to introduce deep into the sinuses. That is one of the main goal of sinus surgery nowadays, to introduce topicals deep into the mucosa, into the sinus mucosa, where actually the disease is happening. So it avoids the need of oral steroids in the future. That is one of the biggest, target of sinus surgery, or the biggest goal of the sinus surgery in the current times. And most importantly, by means of surgical exercise, you reduce the inflammatory load. What I mean to say, this is a medical disease. We all know what has been taught. The maximum medical treatment is the answer to this problem. You give maximum medical treatment in terms of sometimes antibiotics, steroids, whatever. But you cannot go beyond a limit. You cannot continue with the oral steroids for long because of their ongoing, side effects, their adverse effects of the oral steroids. So you have to limit your medical treatment at certain limits. And that is defined by the inflammatory load. If some patient has a small inflammatory load, can be tackled by the topical steroid, there is no need of sinus surgery. That concept still works. This is just the beginning. I'll tell you what I'm saying and why I'm saying. But if the disease load is too much, oral steroid is the need of the time to continue for the long term, which is not advisable, not possible. And then you need to reduce the inflammatory load by means of some surgical exercise. And where comes the role of the sinus surgery? So the role of sinus surgery is three-pronged nowadays. Obviously, to establish the ventilation and drainage, to maintain the sinus physiology, to bring back the sinus physiology to normal, to give access to the topical steroids so that you can avoid the need of the oral steroids in the future, And thirdly, and the most importantly, to reduce the inflammatory load, so that whatever remaining inflammatory load can be tackled with a minimal topical steroid rather than the need of the oral steroids. That is the present goal of the sinus surgery. And this, see, what we expect from a sinus surgery, like a patient with a polyposis, which is one of the common manifestations for the difficult sinusitis condition. Sinusitis, as I said, is a faceted disease with a lot of pathophysiological process, a lot of endotypes and phenotypes there. So this is one of the common thing which we see in our practice, the polyposis. And the goal of the entire surgery is to achieve this kind of a cavity. Establish ventilation drainage, give good access for the topicals to reach everywhere. And here comes the role of surgery or a good surgical exercise to give you a cavity where the patient himself can introduce the topical steroids into the depth of the cavity. And the third one is to bring back the mucosa to normal, to reduce the inflammation of the mucosa back to normal, to relieve the symptoms. That is what the goal of the present, sinus surgery in the present era. Now, coming to the definition, next 10 minutes for the basic, and then we'll go with the clinical scenarios. This definition is very important. The biggest problem, why we are gathered here to discuss how to improve the outcome. And for that, the most important thing is to reach to correct diagnosis. Diagnosis of CRS or the chronic rhinosinusitis is always clinical. Never on the basis of any other thing than clinical. And most of the time you diagnose by means of one or two major symptoms of CRS extending or continuing beyond 12 weeks to label it as a chronic one, along with some minor symptoms, along with some endoscopic and radiological confirmation. It's not like one thing you get a CT scan done, you see some opacity can be labeled as CRS. If the symptomatology is not supporting, it cannot be CRS. If you see something in the nose looking like CRS, and if the symptomatology is not supporting, it is not CRS. So a correct diagnosis is very important to reach to a correct outcome. For example, the facial pain or whatever is one of the major symptoms. Most of the time, even the patient comes to you that I have a sinus pain. You get a CT scan, you see some opacity. You get 100 patient CT scan done, and 10 to 20% you'll get some or other opacity labeled as a sinus disease, which actually is not a sinus disease. So we need to define what exactly that facial pain is corroborating to the sinus disease or something else. To label the facial pain for the sinus region or sinusogenic origin, it has to be supported by the fact that the pain is relieved by the medication like antibiotic or steroids, and it aggravates with the episodes of viral infection or something, or it has to be some endoscopic confirmation of signs like polyp or some purulence or something in the middle meatus or in the nose to confirm that pain to be the sinusogenic. So your symptomatology is very important to understand, as this disease can be misdiagnosed many a times as a CRS, and you start operating on a CRS for something else. Because whenever you confirm by means of a CT scan only, you will find some or other opacity, even in the normal individuals, which comes after a small viral episode or could be sometimes persisting for some other past reasons, not because of CRS. So the correct diagnosis is very important. In general, how many CRS patients we ENT guys are treating? Pure CRS cases, less than 10%. 10% is even a big number, I am telling you. Majority of these patients are being treated by either GPs or general physicians, because the symptomatology of these, CRS symptomatology is so overlapping. Any patient coming with a nasal blockage pain or some cold or some kind of patient always complain of feeling of cold, sneezing or something like that. And the GPs have a habit, or the physicians always give a course of antibiotic steroid, and somehow the patient gets relieved. ENTs, what we are getting are actually less than 10% patients of actual CRS, and most of the patients are either being treated by the GP or general physician, misdiagnosed, mistreated, and patient keep on taking steroids to control their symptom most often. Even the homeopath, what they give the steroids, and the patient gets relieved. And because patients have the habit of trying to get up from the surgical exercise, get to allopathic doctors. So most of the time it is misdiagnosed, and a correct diagnosis is desired to get a correct result. And what you can take the help of this scoring. This is our preferred method of scoring, sinonasal outcome score SNOT 22. This is very, very simple, very important, and prevents you from getting, diverted to some other pathology, misdiagnosis from medical legal problems, and so on. In the simplified manner, these are 22 symptoms related to the sinus disease, primarily or distantly related to the sinus disease, which a patient can complain of. And in terms of scoring from grade 1 to grade 5, for 22, 5 times 110 is the scoring which patient has to score his symptoms. Like, for example, why it is important? If you start scoring SNOT 22, your 90% of the problem of diagnosis and other issues can be easily resolved, because this is purely patient-centered decision making. Many a times you have to take decision whether to operate or not. This SNOT 22 will help you, as this is always where the patient is involved in the decision making process. So simply, what is, if the patient complains of some symptoms like, I have problem in the sleep, I get up early in the morning, I have problem in the throat, I have some sticky discharge in the throat, some nonsense, I have headache, some XYZ problems which are not related to CRS, you can easily diagnose that this is not the correct diagnosis, because ultimately CRS has to be diagnosed on the basis of clinical grounds. If the patient symptomatology doesn't warrant to a CRS, there is no point in taking forward the case for the CRS treatment. So what happens with the SNOT 22? The patient's symptomatology will tell you whether exactly this patient is a patient of CRS. So this form is given to the patient fills up and tell you that, and you get to know that these are the problems with the patient with their grading. This helps you in the further follow-up also, that how much the patient is relieved of their problem. If anything more to be, need to be treated, if patient is more and more focused on the headache, you may not need to involve the neurologist or refer some neurologist or something like that. So it prevents misdiagnosis, it involves patient in the problem, it involves the patient in decision to take a call for the face. Many a times it's a very, very difficult decision. What happens? You have given maximum medical treatment, patient is getting relieved, you are giving again and again antibiotic steroid course, patient is getting relieved, and you have to ultimately take a call for the sinus surgery. And with this, with the patient's reported symptomatology, it helps patient to understand better that you really need surgery, or symptoms are not coming under control with the medical treatment, and you can take a better call, taking the patient in confidence that the surgery is required, and it helps avoiding you a lot of medical legal problems. So this SNOT 22 scoring is a very simple scoring. Just give this pro forma to the patient, and every time even in the follow-up, you can get the pro forma done, so that you can get to know what exactly the problem is going on, whether it is actually CRS or something else, and patient is always, in the loop of the decision-making process. Now, coming to the CRS, by and large, what we see in clinical practice, there are two types of CRS. One is polypoidal, one is non-polypoidal, with some purulence or something, or secretions in the middle meatus. What we see, these are clinical manifestations with a polyp and without polyp, though it has a difference in terms of the pathophysiology process going on inside. The polyp has a different pathway going on, and non-polypoidal has a different pathway, and different prognosis, different treatment, everything is different. But this is not everything. Even in the polypoid disease, why I'm sharing all this, there are lots of endotype discovered now. Same polyp patient could be having different pathophysiologic mechanism, number of different pathophysiologic mechanism, and each pathophysiology mechanism has a different answer, different target, and a different outcome. And if we treat all them in the same line, we cannot have a expected outcome, what you believe. So this is simple manifestation, clinical manifestation, we divide into polypoidal and non-polypoidal category. Now, to understand this progress in the science, we need to understand what exactly we have found as targets for the treatment. As I'll share with you all the 4,000 articles, you can even more go into the depth and find more and more, as a think tank, you can work on it and found more and more targets to define a better treatment. So what exactly this disease is, in next 5 minutes, like our body's defense mechanism, our sinonasal cavity also is a defense mechanism. and it is governed by several factors. This is so important to understand, because every time when we come to a different endotype, we have to move back to this, that what exactly we are treating. This is inflammatory condition. This is dysregulated immunity. Our body's sinonasal cavity has an immunity for the pathogens, because we are exposed to the pathogen all the time, whatever we inhale from the environment, toxins, microbes, and so many other things. And the sinonasal epithelium has a ability to combat all those challenges effectively. And if that immunity is maintained, we are away from all these problems. So that immunity is governed by, at the epithelium level, by three things: the epithelium junctions, tight junctions, then the mucociliary activity, that the mucus is covering the epithelium, and the ciliary activity propels the mucus. Whatever challenge come from the environment, it trapped by the mucus and expelled to the nasopharynx and then to the gut. And the third one is, there are lots of, more than 1,000 variety of antimicrobial proteins which are secreted by the epithelium to combat every individual different challenge. And this is so important to understand. This is the one of the main site of the research work, to assess what is the deficiency at the mucosal level which can be covered, or which is responsible for the disease, and which can be covered as a target for the future better treatment. Like a lot of antimicrobial protein, cathelicidin is one of the most important antimicrobial protein, and it is improved by the vitamin D. So all those patients who are severely deficient with vitamin D have inability to produce more cathelicidins, and have more, immune dysfunction, and can lead to problems. So there are so many targets have been defined which are responsible. The hypofunction of that is responsible for the, lack of immunity. And if some challenge comes to the mucosa, what happens? Our mucosal immunity, whatever comes to the mucosa, epithelium, mucociliary junction, and all these proteins combat them and expel. And if the immunity is down, that challenge enters the mucosa and stimulates the adaptive immunity, and which is responsible to combat that challenge. If that immunity is dysregulated, the whole exercise, the symptomatology of CRS happens. That is the simple core thing we need to understand. See this. If this is one slide explains everything every time, because this is the point which has helped us defining new targets. As I said, the future is medical treatment, and this is how understanding this cascade as defined as a new target to treat this CRS in a better manner. So whatever antigen, whatever challenge which is able to cross the mucosa is attached to the receptors at the mucosal level, and that starts immune response by means of a lot of, cytokines, dendritic cells, and every antigen, every challenge has the ability to induce a different pathway. Those challenges which, for example, the challenges which is so severe in terms of immune disturbance, which stimulate the T helper cell, two kind of cells, to stimulate the interleukin 4, 5, 13 to give us a eosinophilic recruitment, and, immunoglobulin E recruitment, and lots of mast cells, basophils, and immunoglobulin E, and orchestrate different kind of a severe inflammation leading to the polyposis. That is one pathway. Other pathway is stimulating T helper 1 cell to bring in the neutrophils in the actions, and then other group of cytokines in action, and give a non-polypoidal disease. So it depends upon the challenge which has come through the mucosa to incite what kind of pathway is going to be stimulated. And that is the core concept we need to understand, because understanding these pathways has given us new target. What we are seeing as the polyps and non-polypoidal disease is a manifestation, clinical manifestation. And what is happening at the molecular level is what is here. If we block the disease process at the molecular level, we need not to reach to the, treatment to the clinical manifestations. All disease can be curbed at the molecular level before reaching to the level of clinical manifestation, and that is the future. That is what happened in the cancer treatment also. The targets have been defined. The targeted monoclonal antibodies are the treatment of choice, like for lymphomas. Lymphomas, no need of surgeries. The molecular targets are defined for each and every variety of lymphoma, and that targeted therapy is the cure for that cancer. That is going to happen for all cancers. And same is the future for kind of this disease. This is a pure immune complex disease wherein a dysregulated immunity is responsible for a, kind of clinical manifestation because of the, according to the challenge. Like for examples, these, if we block the molecular pathway at this level to produce interleukin 25, 23, at the level of, block the interleukin 5, interleukin 4, interleukin 13, we can further, prevent the manifestations of CRS by means of polyps, by means of immunoglobulin E recruitment, and by means of other things. So the target, the aim is to define the molecular targets for the future treatment, and which is going to establish as the future core treatment of CRS rather than the sinus surgery. There are many other hypotheses. One of them is the bitter test theory. It has been very, very popular as one of the theories to, give progress to the CRS. We all know this is inflammatory disease. This is not infective disease. The microbes have no role except to modify the course of disease. Similarly, there are lots of defense mechanisms, and one of them is the test receptor. Test receptors are not only on the tongue, but in the entire airway, and one of them is T2R38. It is very, very important test receptors, which are the ligands for acyl hormone lactose given off by the gram-negative bacteria. They sense gram-negative bacteria very early, and once they sense the gram-negative bacteria, it opens up the nitrous oxide challenge, opens up calcium ions, and the mucociliary activity is exaggerated, and those gram-negatives can be expelled out. So it is a very, very strong mechanisms to combat gram-negative mechanism, and one of the, mutation of this test receptor leads to CRS. This has been documented several times, and in the clinical sense, those are good bitter testers are unlikely to have CRS. This has been very, very proven. You can test yourself if you are a good bitter tester or not, and you can have a sort of good immunity against the development of the CRS in the future. So this is one of the, future, you can say. So what we have achieved by this understanding, we have found a lot of new targets. We have understood the pathophysiologic mechanism going on behind development of the CRS. And these targeted therapies are approved by the FDA. Many for the, treatment of the asthma, which is the same drivers of inflammation ongoing. What we are discussing at the upper airway CRS, the same kind of drivers are involved in the pathophysiology of asthma at the lower airway level. CRS, you can say in the simplest term, as the asthma of the upper airway. The same interleukins, same cytokines, same drivers of inflammation are involved at the lower airway epithelium, which are at the upper airway epithelium. So there are new targets, and many of these, monoclonal antibodies are developed and marketed by many companies, and a lot of being, used in the lower airway for the severe asthma. Now, since many of the targets have been redefined, now we have many of the options to use the monoclonal antibodies for the particular kind of CRS. I said CRS has various endotypes. Every endotype has a different pathophysiologic process, and to tailor the treatment according to pathophysiology, the various monoclonal antibodies are available. Though the way is far off for them to come to the clinical practice for the regular use, but yes, in 10-15 years down the line, as more and more research work is going on, they are going to establish themselves as a core medical treatment, preventing clinical manifestations of polyps and other things of the CRS, as they're going to be the core treatment. So there are various targets and various monoclonal antibodies which are available in the market. We'll discuss again and again. Now, coming to the diagnosis, we know two things we have been knowing very well, that the endoscoping and CT scan are the most important investigation which are needed in every patient before you take up for surgery or take any call or any decision for sinus surgery or something else. This is not the end. Believe me, why this exercise started again? We operate upon a patient, surgery fails, you can say in broad terms, and patient requires the surgery again as the disease comes back. We need to know what exactly is we are failing, where exactly we are failing, what is the missing link Why we have not understood this disease properly, and these are other investigations which are needed in many of the patients to know the particular disease profile. It is not the endoscopy or CT scan that will show us that it is patient has a CRS. CT scan, again, there is a controversy when to get a CT scan done upfront or later on. Yes, the role of CT scan is just to give us a three-dimensional anatomy of the area where we are operating. Least in the diagnosis. Yes, sometime needed to rule out, to reach a correct diagnosis, to rule out something. Sometimes you have a pathophysiology pointing out to be CRS, but it doesn't turn out to be CRS or severe CRS enough to, needing any endoscopic surgery or something. So the need of the CT scan is sometimes confusing. You may need some time upfront. There are a lot of research now, a lot of publications coming that the upfront CT scan is much better. Because if you are treating for something else, unnecessary medical treatment, offered to the patient for something else which is not required. So it is all your clinical decision when to get a CT scan done, but definitely it is never repeated because it gives the same anatomy. The information is the same as the anatomy doesn't change. So why these all investigations are needed? Please feel free to interrupt any time for any confusion or anything you want to know in your practice or anything you do differently. Yeah, there are lots of mic in the auditorium. You can ask for the mic and ask your question or interrupt me any point of time. So why these all investigations are needing? Patient come to you with a one single question when you are operating upon a cases with a polyposis or something. Doctor, will I need a surgery again? I have come to know this is a notorious disease which requires surgery again and again. How can you answer that? You need to know the profile of the disease, what exactly is happening inside the patient, what kind of a profile of a disease. It may look like a polyp. The same polyp can have a different profile. And to know that what exactly this kind of disease, we need to have a lot of these kind of information. Eosinophilia is one of the most, important factor giving to recalcitrant disease. If there is too much of eosinophilia, serum eosinophilia, mucosal eosinophilia, it is bound to come back as it requires more and more steroids. As I said, steroid works at every cascade of the pathophysiology. What we have seen, the pathophysiological cascade. In the present context, monoclonal antibodies are not available. The only thing which works at every level is steroids. More and more eosinophilia are more severe drivers of inflammation, requiring more and more steroid. If some patient has a severe eosinophilia, you can tell them upfront, it is likely to come back. You need more steroid in the future. You need more aggressive follow-up. You may require a revision surgery, or we may need to do a aggressive surgery upfront to prevent recurrence. So you have to be prepared to deal with a more aggressive situation, something like that. IG is so important. Believe me, as we go in the detailed part of the discussion, IgE is single most important factor in taking a call for the surgery, in taking a call for other adjuvant therapy. For example, if patient has a low serum IgE, any patient coming to you with a low serum IgE with CRS symptoms, CRS symptomatology, CRS CT scan, everything is the diagnosis of CRS. My first answer is not surgery. Those are the patients who respond best to the macrolide antibiotics. So if the IgE is low, the question of surgery is ruled out, and many times, more than 80% of the time, you can cure the patient with a medical treatment only. If the patient has a high IgE, then the situation is again different. High IgE could be because of the allergy. And those are the patients where the allergy is the main driver of inflammation. And those patients require allergic treatment as a prime adjuvant treatment along with the CRS. And if you don't treat allergy, the patient's symptomatology and everything is not going to come under control. So with this, IG gives you a lot of good information about taking a decision making. Very, very disproportionately high IG. One of the, understanding which has been made now is because of Staph aureus infection. Staph aureus gives polyclonal expansion of Ig. It produces enterotoxin, which expanses, which stimulates the Ig production like anything. And the maximum Ig, the patient has a serum Ig 4,000. You can believe that could be having Staph aureus infection, ongoing infection, and you have to direct your treatment according to the Staph aureus could be biofilms, could be intracellular Staph aureus, which is not, amenable to any regular treatment, and that's a difficult patient, and you need to treat accordingly and direct your antibiotics according to the Staph aureus, maybe topical antibiotics or whatever, to deal with that difficult situation. So this profile tells you what exactly the patient is having. Without knowing all this, if you try to operate, there are some other, without understanding the disease, the likely outcome is never possible. So generally, as I said, it's an inflammatory disease. Antibiotics are never needed, rarely needed, I would say. Antibiotics are needed only if there is secondary infection. You can confirm by means of simple, C-reactive proteins, by means of simple culture sensitivity if it is, and direct culture-directed antibiotic, as I'll come later with the concept of microbiome, where you have to preserve microbiome by means of giving minimal antibiotics for this pathology. Immunity is one of the aspects. Many patients will discuss in detail later. A chunk of patients of this disease are immunodeficient. Believe me, we deal with so many revisions. Up to 10% of the patient have some or other defect in the immunity. This is like a syndrome, and if you are not aware of it, you cannot get a desired result. Any patient, this is an inflammatory disease, this is disease because of dysregulated immunity. Anything which has a positive outcome on the overall immune aspect of the patient will have a favorable result. Any treatment which has or anything which has a negative impact on the overall immunity will result in a negative aspect of the treatment and will never give us a desired result. So immunity assessment will come in detail, is a very integral part. On certain patients, we need to know which patient require immune assessment. I'll show with some slides that which patients are group of patients which require a proper immune assessment, which is otherwise overlooked, and start treating the patient on the line of CRS for the sinus surgery. So immune assessment is very important for the desired outcome. Aspirin sensitive testing is one of the important, as it discovers one of the important endotypes of the CRS, one of the endotype which has the most extensive inflammatory aspect on the entire spectrum of CRS. CRS has lots of endotypes, as I'm going to share with you. And one of the endotype which has the most extensive inflammatory spectrum is AERD, aspirin exaggerated respiratory disease, which is most difficult to control. And if you don't understand that pathophysiology and keep treating those patients on the line of the surgery, you operate upon 100 times on those patients and it is bound to come back. So those are the most severe patients, and we need to understand this by means of clinical suspicion and then further aspirin testing and then further treatment. Like, for example, any patient coming with a polyposis, having asthma, must be tested for aspirin sensitivity to confirm as a Samter's triad or aspirin exaggerated respiratory disease. If not confirmed, if those patients not desensitized with the aspirin, however number of times you operate, they are bound to come back with the same disease, because the underlying physiologic process is because of aspirin sensitivity, where a lot of leukotrienes are overproduced, and that is driving the inflammation. So this is very important. So you have to be suspicious all the time with every patient, that what kind of this patient is and what kind of underlying pathophysiology that particular patient has, to treat that patient accordingly. And that is the concept of precision medicine. Every patient has a different underlying pathophysiology. Histopathology we have now adopted as a regular part of our surgical exercise, to send all the specimen or part of the specimen which are part of the representative mucosa for the histopathology. This is very important, and it saves you from a lot of medical legal problems also, besides giving you the insight of the particular patient disease. For example, like the same patient asking you whether my polyps are going to come back, will I need surgery again, doctor? And your answer should be reserved with some information. For some information, like in malignancy, we say, will our further adjuvant therapy will be directed by the final histopathology report. Whether it require chemotherapy, radiation therapy, combination, concurrent, whatever, it depends upon your spread of the disease, whether it has gone to the extracapsular spread, multiple lymph nodes, what exactly the profile is. So mucosal histopathology will give you the most important information about the mucosal eosinophilia. That is one of the most important drivers of the inflammation. If the patient has a severe mucosal eosinophilia, you can tell them your disease is very, very severe. It requires more extensive, more close follow-up, more, long-term steroid irrigations, more long-term follow-up to prevent prevent recurrences and all that. And vitamin D and so many other things we'll discuss, which are, drivers or the things which affect on the immune aspect of the patient. By and large, it is dysregulated immunity, immune complex disease, anything which improve the immune aspect of the patient will have a positive impact, as simple as that. So, CT scan we'll discuss later during the surgical part. Simple, vitamin D. We know vitamin D deficiency is very common, but severe deficiency of vitamin D has a significant impact on the immune aspect of the patient by various methodologies, by various regions. Vitamin D affects the immune system of the patient. Many a time, severe vitamin D deficient patients become steroid insensitive because vitamin D stimulates the glucocorticoid receptors. And we have seen many of the CRS patients, particularly AFRS patients, where the vitamin D level is 10 times below, and those definitely improve with the vitamin D supplementation.
Good morning, boss.
For their overall
morning,
treatment.
boss.
Yes, sir.
Yes, Dr. Ajay Gupta from Tata Main Hospital.
Please,
Jamshedpur.
please.
Sir, will you be further elaborating upon the aspirin hypersensitivity testing, how it is done, and in what setup we should be doing this? Would you be further elaborating in
Yeah, I will show
future
you details
sessions?
in the next slides.
Yeah,
But since you have asked, aspirin sensitivity should be done in all patients, all polyp patients who have asthma. By and large, polyp patients having asthma have more than 20% chance of having AERD. In general, all polyp patients, up to 5 to 7% patients are having AERD, which goes underdiagnosed, undiagnosed, and you keep on repeatedly operating on those patients. If you remain undiagnosed, it's never going to cure your patient. In general, 10 to 15% of the patients who are asthmatic may not be having polyps, have AERD. So this is not uncommon, but this remains underdiagnosed. And this is one of the important aspects of the disease. I'll come to the asthma part and tell you, you make your pulmonologist your friend, your practice will be doubled. Believe me. This CRS is so underdiagnosed, misdiagnosed. As I said, less than 10% of the patients are being treated by the otolaryngologist. Those patients are being treated by the GPs, considering as a common cold or something else, which are actually CRS patients. And ultimately, they develop lower airway problems because this is a unified airway. So those CRS patients being treated by the GPs, ultimately they become asthmatic, and then they move on to the pulmonologist. Again, otolaryngologist is nowhere in the scene. And if you retrospectively see all those asthmatics or any asthmatic patient, you get 100 asthmatic patients requiring oral steroid, topical steroids or inhalational steroids for their control of their symptoms. Out of 100 patients, more than 60% have CRS. Primarily CRS, for which they were being treated by the GPs, since they overlook the nasal symptoms coming to the otolaryngologist. But once they develop lower airway symptoms, then they go to the pulmonologist, considering as a major problem. And pulmonologists will never look at the upper airway, never look at the sinuses, and keep on giving inhalational steroids and other things. So your ENT patients primarily were, with the GPs and then finally with the pulmonologists, and you are nowhere in the scene. So make pulmonologists your friends. 80% of the asthma patients can be cured. If not cured, the need of asthma medication can be reduced to maximally low. You can reduce 90% of the medication of the asthma patient by treatment of the CRS. But that is not happening because of lack of coordination amongst pulmonologists and ENT surgeons. So that requires a close call, close coordinations among them. And if you have pulmonologist friend and you have a good coordination, and this is for the patient benefit, all those poor patients otherwise on inhalational oral steroid for life, pulmonologist will never send to ENT for the CRS management. It is never going to happen. The pulmonologist is sending to you unless you convince them about this unified airway concept and convince them that actually it is the CRS which has led to asthma. It is not primarily endogenous asthma. which percentage of the Indonesian asthma is very less. It is secondary asthma because of the upper airway problem, which undiagnosed, untreated upper airway, which led to the lower airway problem, and which actually should be treated by the otolaryngologist by means of treatment of CRS, because the drivers of inflammation are same. So such a huge, chunk of CRS patients are lying with the pulmonologist and being treated unnecessarily with lots of steroids for the asthma. So we'll discuss this AERD later, sir. So vitamin D has a lot of role and it has a lot of immunomodulatory functions. We have seen the CRS cascade earlier. This vitamin D works at lots of level of the CRS, pathophysiologic cascade to improve the overall immunity. Anything which improve the immunity is going to have a positive impact, and vitamin D is one of the factors which has a, huge positive impact. Particularly those patients who are severely deficient should be supplemented and improve the. See, in our hands for this medical disease, we have nothing more to treat for the surgical aspect. For medical treatment, we have hardly anything, just to give oral topical steroid or saline irrigation, something. So anything which improve the immunity, we need to look always for that and do something to improve the immunity. And now we have understood in our medical treatment, we have a lot of things in the basket to improve the immunity. By means of how this thinking has come, by means of understanding this pathophysiological targets, this pathophysiological process we have understood. And this is the histopathology report which we have given to our pathologists to report always on this. Yes, sir. Mike, yeah.
They usually do vitamin D3. So what is your comment on that?
Yes,
Because
so vitamin D3 is what we can measure. Your question is right. Let me answer your actual problem. That's a good question. What we measure is a circulating vitamin D3. That is not active form which works at the cellular level. You know how the vitamin D is produced. Either we take as an oral intake, or the 7-dehydrocholesterol in the skin is transformed by the UV rays from the sunlight to vitamin D. And that vitamin D is circulatory form of vitamin D. To become active, it has to be hydroxylated twice, once in liver, once in kidney again, to become 125 hydroxy vitamin D, which is the active form. And for that, there are various receptors on the airway cells. So what we measure is the circulatory vitamin D, and that is what the thing which can measure. If you have insufficient circulatory vitamin D, obviously you will have insufficient, active vitamin D form. So that is what we can measure, and we have to look at that way on that part.
So one thing, in how will we differentiate between allergic rhinitis and chronic rhinosinusitis? Because the chart you have given, two things like blockage and nasal discharge is also present in allergic rhinitis, and
symptomatology is overlapping. You are right. See, allergic rhinitis is a type 1 hypersensitivity reaction to some environmental allergen, which is otherwise harmless, but the body is considering harmful and react strongly by means of IgE mediated mechanism. So symptomatology of allergy is altogether different by means of predominance of sneezing, watery discharge, itching in the eyes, itching in the skin or somewhere else. So those are the predominant symptoms. CRS has a different predominant symptomatology as compared to this. Sometimes the patient may have associated allergy. More than 60% of the polypoidal sinusitis patients have associated allergy. So treatment of allergy is one of the most important adjuvant therapy, the CRS. Otherwise, your question is valid. Sometimes you have given a good treatment for the CRS, but overlook the allergy, and the patient will come back with the same. I have again the running nose, I have the obstruction, doctor, your surgery has failed. It's not the surgery has failed. You have overlooked the adjuvant, the comorbidity which you have not treated, which requires a definitive treatment by means of symptomatology and immunotherapy and other things. So that is important. So what, in the present context, what are you left with? What are the management options? Now the clinical scenario start. What can we do as a part of medical treatment to this disease? This is very, very important. Every patient is not surgical patient. And what best medical treatment we can give in the present context, looking at the, taking the advantage of the recent research work. So we have seen the pathophysiological cascade of CRS development. And in the present context, the only thing which works at every level is the corticosteroid. It improves the innate immunity, it improves the adaptive immunity, it reduces the secretions of cytokines and everything to bring back the cytokine cascade, which is aggravated in the CRS. So we can give steroids as a powerful, as a weapon, what we can say as the only weapon which works effectively in CRS patient. But we have our own reservations. We cannot continue oral steroid for long because of their own adverse effects. So what we are left with the choice of topical steroids. And what are the topical steroids in the present context? The most, I would say, the generation steroids are the mometasone and fluticasone, which are safest one with least bioavailability, less than 1% to the systemic circulation. So that's the only choice we are left with in the present context as far as the medical treatment is concerned. Looking at the CRS cascade, we have understood this fact that steroid works at every level, and we have only option is topical steroids. Now, if the patient inflammatory load is too much, too high to be taken by the topical steroid, then how the patient symptom will be under control, how the CRS will come under control. So now there comes the role of sinus surgery. If the inflammatory load is low, steroid is the treatment, topical steroid is the treatment. Yes, you can give. Sometimes you have an acute symptom, acute load, you can give an oral steroid for a small course of oral steroid for 5-10 days. In between, not so much, because they have their own adverse effect. In our country, we can give steroid randomly to every patient without keeping a record. But in the Western countries, you have to keep a track record of every single dose of steroid given in the particular year, because the cumulative dose of steroid has an impact on lots of systemic comorbidities. So oral steroids, we have our limitations, and what we have left with as a weapon is the topical steroid. And those patients who have inflammatory load, this is too much to be taken by topical steroid, require sinus surgery. That's the indication for sinus surgery in general. So the role of sinus surgery, I said in the beginning, is three-pronged. If the inflammatory load is too much, the sinus surgery will reduce the inflammatory load, and then that reduced inflammatory load can be taken care of by the topical steroids again. But the things have changed after the sinus surgery. Before sinus surgery, as the sinuses were unopened, our option was to use only nasal sprays, which do not cross beyond anterior 1/3 of the nasal cavity. And what we need, the sprays of the steroid at the destination where the mucosal disease in the deep in the sinuses. But now after the sinus surgery, the things have changed. The goal of sinus surgery, I mentioned in the beginning, is to give wide openings to introduce the topical steroid in the depth. So in that scenario, in the post-operative scenario, now we have an option to introduce the topical steroid in the depth. That is the second advantage of sinus surgery. Besides reducing the inflammatory load, besides establishing the ventilation drainage, it gives you and it opens up the avenues for the topical steroids to reach in the depth. And we have lots of mechanics involved. There are lots of ways to introduce those high-dose topical steroids in the depth of the sinuses. The advantage is you can use high-dose steroids right at the destination, at the desired place, at the desired mucosal level, yet without systemic side effect. That's the biggest, advantage of the sinus surgery in the present context. So these are the, advantages of the sinus surgery. But in the future, as I said, yes, please. Yes. So I'll come with that concept later on. Your point is right. Microbiome. We need good bacteria to improve immunity. I have already mentioned anything which improves the sinonasal immunity or overall immunity of the body will have a positive impact. And one of them is strengthening the good bacteria. That is one of the most important concepts. I'll come very soon. The concept of microbiome, which is important, very important, and a lot of therapeutic strategies have come to improve that. So in the present context, beside the medical treatment, if medical treatment fails, then surgical treatment fails. And in the future, is the targeted therapy. So even now, in the present context, FDA has approved dupilumab as one of the monoclonal antibody for the use for CRS type 2 CRS, CRS with polyposis in severe conditions. So what are the indications in the present context? You can use monoclonal antibodies in the present scenario also in certain group of patients where you cannot do sinus surgery. Where still the disease is not coming under control with the sinus surgery are the indications for biologic therapy or monoclonal antibodies. If your disease is severely uncontrolled, requiring oral steroid every now and then, you cannot give oral steroid every now and then. And those are the true patients for the dupilumab therapy, which has been approved by the FDA. And even we can buy the dupilumab, which is being marketed by the Novartis nowadays. And you can treat those patients, though it's a very, very expensive drug, but still it has resolved its place even in the present context. I know I have already told it is going to be the future 10, 15 years down the line when the cost comes down and when a lot of other things are much clearer in terms of long-term adverse events and, efficacy. But even in the present context, the dupilumab is available and is reserved for these patients which have severe uncontrolled steroid-resistant disease and which have severe quality of life improvement, and their asthma, in spite of all measures, in spite of inhalation or oral steroids still not coming under control, are the real candidates for dupilumab therapy. Those patients who have severe symptoms cannot undergo sinus surgery because of their fitness issues and other issues and other comorbidities, other systemic comorbidities, are real candidates for the biologic therapy or dupilumab therapy. Dupilumab, because that's the only biologic which is approved for the treatment for CRS. There are so many other omalizumab, anti-IgE, mepolizumab, anti-IL-5 are available for the treatment for this disease, but at the lower airway for the asthma, not for the upper airway. So for the upper airway, the only option we have nowadays, which the FDA has approved, is the dupilumab. But there are limitations. Look at the cost. The annual cost, every 2 weeks you have to give an injection, and it costs the hell of a money for the people like in our country. So there are things to be established in the times to come, and the cost is going to come down for sure as more and more production done by the other companies, and a lot of other issues will be settled down the line, like long-term efficacy, long-term adverse event. We have to identify the true responders, the markers for the patient who are going to respond to the biologics, who are not going to respond to the biologics, and how long is going to be the treatment, what is the end point of treatment. So much still has to be defined and to establish as a, the preferred treatment for this disease at the molecular level, targeted therapy like it has been established for the treatment of lymphoma and other diseases. And in times to come, this is going to be the established treatment, not the sinus surgery, because that is clinical manifestations we are treating, not at the disease at the molecular level. So what we can do in the present context, as I said, we can give topical steroids, we can give oral steroids sometimes. There are other drugs which have some place, because since we are left with limited weapons, we are looking for more and more, drugs, more and more therapies which can have some or other effect on the CRS before the targeted therapies have, comes. So for by and large, for the polypoidal disease, yes, obviously for any disease, polypoidal, non-polypoidal, saline irrigation is the core part of the treatment. Every prescription should involve saline irrigation. And this is something which drives away the inflammatory mediators from the nasal cavity and from the mucosal surface, from the microbes and so many environmental things, and improve the mucociliary clearance. So that is one of the most important part of the innate immunity, and which is improved by the saline irrigation. So these patients should be, any CRS patient should always be subjected for saline irrigation. For polypoidal disease, topical steroid with burst of oral steroid courses in between if they have severe symptoms, in between, not always. So oral corticosteroid should be limited, but a topical is the answer. These are the weapons in our basket in the present context. If they don't work, sinus surgery is the answer, as simple as that. So other drugs which works and we use in our practice is doxycycline for the polypoidal disease. It has a huge impact in terms of reducing the inflammation, not as an antibiotic. We all know doxycycline has been a, antibiotic being used for ages, but this is not being used as an antibiotic here as an immunomodulator. And it exerts immunomodulatory effects by several ways. I'll come later. and Montelukast, particularly for the lower airway, the receptors more and more in the lower airway, not in the upper airway. But some patients have, associated lower airway symptoms. There you can add on Montelukast too. These are the ways to reduce the inflammation to certain extent. If the patient can maintain control symptoms with reduced inflammation with all these therapy, there is no need of surgery. If still the symptoms persist, the disease persists, then you have to take a call. That's the way. And for the non-polypoidal disease, which has a different pathophysiology undergoing neutrophilic predominance pathophysiology, for them, steroids have hardly any role. The target is neutrophils. Antibiotics are the mainstay of treatment. And for these patients nowadays, the macrolides have come up as a big treatment, and more than 80% of the non-polypoidal disease, non-polypoidal sinusitis, believe me, can be cured with a medical treatment. There is no need of surgery. As far as the, if we divide the overall patients of sinusitis, what percent of the cases are polypoidal, what percentage are non-polypoidal? More than 80% are non-polypoidal. Those are not difficult to treat kind of sinusitis, more than 80%. And those are the patients who have a different profile. Those patients can be treated on medical treatment by means of macrolide. I am coming on that. And those are the patients who are not eosinophilic driven. That is a very, very important part. And those patients are our target to treat with the medical disease. And they have hardly any role with the steroids. So, and by and large, antifungals have no place in the overall treatment of CRS. There is no point in giving by any means antifungal for any non-invasive fungal pathology or any kind of CRS. There are a lot of people have a, practice to give antifungal. There has been theory proposed by the fungal theory for the CRS, causation and everything. It has been all ruled out very, very clearly now. And antifungals have practically zero role in the overall treatments of CRS. So steroids, topical steroids are the mainstay. And being topical, they have excellent safety profile. That's why we are using. We cannot use oral steroid every now and then. And these topicals have effect at every level of the CRS cascade. That's the point. They reduce all the cytokines involved. They reduce immunoglobulin E. They reduce interleukins. Everything they reduce, and that's why we are using. And fluticasone, mometasone are the most popular one. But the only disadvantage is they don't penetrate beyond anterior 1/3 of the nasal cavity. So we have our, the limited effect of these topical. But systemic definitely has a huge impact, but we use them preferentially in certain situations, like short-term management, like improving the surgical field before surgery to blunt the inflammation. See, what happens in the CRS surgery, what happens in the sinus surgery, in any endoscopic surgery, we want a good surgical field. And with the ongoing inflammation, this kind of inflammation going on, this vasodilation lead to a lot of bleeding, and in order to control the bleeding, you have to curb the inflammation, and then preoperative course of steroids is very, very important in such polypoidal eosinophilic disease, and even in the post-op period to reduce the inflammation, they work well. Otherwise, there is no role of using, or we should avoid using systemic steroids every now and then for the polypoidal disease. This doxycycline, as I mentioned, has a lot of impact. It is anti-staphylococci drug. Besides that, it has a lot of immunomodulatory effects. And these immunomodulatory effects are the primary reason for directing the use of doxycycline, not as an antibiotic where doxycycline is used. And this is very, very important in a polypoidal disease where the tissue edema is mainly because of the activity of the metalloproteinases, which is inhibited by the doxycycline. We give a course of doxycycline to our patients. First day 200 milligram and then 100 milligram once a day for at least 3 weeks, and it reduces the inflammation along with a short course of oral steroid to the maximum what we can achieve by the medical treatment in polypoidal disease. Besides that, if it doesn't work, then you have to consider sinuses. There is no other way, no weapon in the present context as far as the medical treatment for the polypoidal disease is concerned at the maximum level. Now, the most important thing are the macrolides. Macrolides, to me, in sinusitis are called as wonder drugs. wonder drugs, though they are bacteriostatic, but they work at every level. Every difficult situation you can think of in sinusitis, the macrolides work. They have the tendency to accumulate intracellular, not only in the serum, but in the intracellular, in the leukocytes, wherever the inflammation is there, they reach very fast and they work very well. And they prevent formation of biofilms by several mechanisms. In inflammatory disease, in the non-polypoidal sinusitis, the major factor limiting our treatment or the major obstacle in the success of the treatment are the biofilms. And this macrolides, they exert so many activities. They prevent the formation of biofilm by means of preventing quorum sensing, by means of preventing polysaccharide shell around them, by means of preventing lots of other materials which prevent biofilm formation or disrupt the biofilm. But by and large, the macrolides act at the neutrophils. So wherever is the neutrophilic activity, macrolides work. Wherever the difficult bacteria, intracellular macrolide work. Wherever the immunodeficiency patient, macrolide works. Wherever is the osteitis, bony inflammation, everything, macrolide work. They prevent bony osteitis and so many things. So out of the macrolides, we all know, in our practice, clarithromycin, azithromycin, and so many things. In our practice, mostly we use clarithromycin in low doses for months together. And they bring down the inflammation. Most of 80% or more than 80% of the non-polypoidal sinusitis can be cured by the macrolides alone. Low dose, long-term macrolides, you have to be careful. You have to involve sometimes physician when you give macrolides. So the elderly patient with multiple systemic disease, because they have a lot of drug interaction sometimes, particularly the cardiac patients and other patients. So we have our physician in team to take care of that. But in those all difficult patients, we give azithromycin. Otherwise, clarithromycin is the drug of choice as a macrolide wherever we use. So at the sinusitis cascade, you have seen the earlier, the CRS cascade. This macrolide drug as a wonder drug, it works at every level of the sinusitis cascade by means of improving the immunity, by means of reducing the drivers of the immunity, by means of reducing the cytokines of the immunity, and they are considered as a wonder drug in sinusitis at every level. But how to choose the patient for macrolide? Whom to give, whom not to give? By and large, all steroid-resistant patients should be given macrolides. All patients, I said in the beginning, one of the most important tests in our, in our list is the IgE, and all those patients who have either normal or low Ig should be given preferentially, irrespective of the disease status, whether polyps or not, should be given macrolides or should be offered macrolides as a primary treatment for all those patients, because they have maximum efficacy in those situations. Patients who primarily present with certain symptoms like post-nasal drip, facial pain, those are the symptoms which are related to the impaired mucociliary activity, and those symptoms are best improved by the mucolides, as they have a positive impact on the mucus secretion, mucus rheology, and so many things that improve the overall mucus. And these are the patients where we should avoid giving mucolides, as these are the poor responders of the mucolides, you can say. So macrolides can be given in many or maximum CRS conditions. Many times, even in the eosinophilic condition, when there is associated neutrophilic inflammation. But in these situations, particularly in allergic patient, we should avoid giving macrolide. Macrolides have no role when there is abundance of Ig, when there is allergy. Otherwise, the macrolides work everywhere. So, as I said in the beginning, this CRS is like a syndrome. Syndrome means there are lots of things which affect the CRS outcome. And if you ignore any of them, the likely outcome of the CRS treatment is something you will never get. So you need to understand those comorbidities. We should not overlook these comorbidities, and we should treat them together to get good outcome. And these have lots of prognostic values also to prevent medical legal issues and all that. So, for example, we have understood, like we discussed earlier, this is unified airway concept. Upper airway and lower airway are same unified airway, part of the same airway, and the drivers of inflammation or the mucosal disease in the both upper and lower airway, our airway is driven by same cytokines and inflammatory molecules. So this is a very complex relationship between the upper airway and lower airway. And by understanding these concepts, like sir asked about the allergic rhinitis, we must treat allergic rhinitis as a comorbidity, as a lot of sinusitis endotypes. I am coming to the different endotypes of sinusitis now. Some of the endotypes are purely allergic driven, like AFRS is pure allergy. CCAD, central compartment atopic disease, is pure allergy. And those endotypes sometimes, or they almost always, they deserve a proper treatment of the allergy simultaneously. Otherwise, the desired effect cannot be, ascertained in those situations. So allergy is something. If somebody asks you that is allergy responsible for CRS? Yes, for some of the endotypes of the CRS, allergy is responsible. Otherwise, allergy gives you, because the same inflammatory drivers are used in the allergy, same IgE, same type 2 inflammatory drivers are involved in the allergy causation. It gives the same pro-inflammatory stage where the CRS can easily establish its place. So it gives you, it primes the mucosa for the CRS to establish later on. So treatment of the allergy is very important in those situations, and particularly when allergy is associated with some anatomical variants which can predispose to the CRS. So it is a unified airway. And as sir asked earlier about the asthma, this is one of the most important part we need to understand. Many of the CRS patients, particularly polyp patients, more than 60% ultimately over the period of time develop or become asthmatic. And many of the asthmatic, as I said, more than 80% of the secondary asthma, which is most prevalent, have some or other form of CRS. So make pulmonologists your friend, convince them, discuss with them, go to the pulmonology conferences, present your work about this unified concept, and you will definitely able to convince them to make a shared decision making on this subject, as majority of the asthma patients are being unnecessarily treated with unnecessarily oral or inhalation, whatever steroids. If their CRS is treated, the need of asthma medication can be brought down by 90%. And that is something amazing. And that's an amazing concept we need to understand and convince our pulmonology friends. Majority of the asthma patients are actually the candidates. They have severe, inflammatory profile. Asthma patient who has asthma, who had CRS earlier and now develop asthma, has a severe inflammatory profile. And majority of those patients are on some form of steroid therapy, and majority are those patients are the candidate for sinus surgery, for the reason that you open up the sinuses and give an ability for the topical steroids to penetrate, to avoid the need of oral steroids in the future. So all those patients coming from the pulmonologist are actually your patient for the sinus surgery. True patients for the sinus surgery are lying with the pulmonologist. What a big, something which has been hidden so far, which is because of the lack of collaboration among these two specialties, the ENT and the pulmonologies, as most of the severe profile patients of CRS disease have developed lower airway problems, are being treated for the lower airway disorder, and the upper airway disorder is ignored, and all those are severe patients which actually require sinus surgery. So the actual sinus surgery candidates are lying with the pulmonologist. So indications of sinus surgery, if you ask me, majority of the patients are lying with the pulmonologist, because those are the patients who had so severe inflammatory profile which has led to the complication and developed lower airway problems. So this is the time to call for a collaboration between the ENT and the pulmonologist to treat these patients, poor patients, for the upper airway or the sinus disease, rather than being treated unnecessarily for the lower airway with lots of steroids and all those things. So other things which can have an impact on the outcome. This is something we have observed in our practice. All this work has come at, all these, what I'm sharing is our experience, how we have seen our failures and how we went to the literature and trying to improve our failure more and more. And this is one of the factors. The patient whom you see who is a candidate for surgery, you have to convince them to quit smoking, and this you can easily counsel them if you use a SNOT 22 scoring. because the patient himself scores in spite of all medical treatment, he is not improving. And this is one of the factor which works at various levels. The smoke has a deleterious effects at various levels at the immune aspect, which leads to, lack of improvement in the overall treatment. So it impairs ciliary function, which is one of the most important desired, factor for the improvement in the sinus disease. So many things, it works at the mucosal level. The smoke has a deleterious effect and has a negative impact on the overall outcome. And we should encourage these patients to quit smoking. If they don't, they should understand that they are becoming obstacle to their better outcomes. Similarly, the CSOM. See, this has been 100 years old dictum. Before you go to the ear, before you treat ear, you must look into the nose. And in the present era, because of the surgical era, this is becoming less and less. At the moment you see the ear patient, you start thinking of operating. If you have a central perforation, cholesteatoma, you start thinking about operating upon that without looking to the nose. There are reasons to believe that this is a part of the upper airway, unified airway. Unified airway is upper airway that includes nose, paranasal sinuses, include eustachian tube and middle ear mucosa, and the lower airway. So this is the entire unified airway. The same pathophysiological mechanism of the upper airway are involved in the ear also. The same inflammatory mediator are involved in the ear pathology. Same microbes you culture from the nose and the ear together because they are same, and the conduit to the eustachian tube. Many of the CRS patients have associated CSOM problem. If not CSOM, eustachian tube issues, otitis media with effusion, retraction, cholesteatoma, and so on. If those patients are being treated, we must look into the nose for the CRS. And if the CRS is not treated, you can't expect the desired outcome. Many times we see we are treating for the cholesteatoma retraction, and again the retraction is coming because the eustachian tube is the major factor. And to prevent eustachian tube from recovering, one of the major factor is CRS. So we should not overlook the treatment of the CRS. When we look at the long-standing ear problem, we must look into the nose. At the same time, what we do in all CRS patients, long-standing such patients, we always get a CT scan done nowadays. And with the same CT scan, we look at the sinuses also. The magnitude of the sinus problem can be ascertained from the same CT scan. And you can change your treatment plan. You can change your counseling if the nose is needing treatment first than the ear to improve your overall outcome, rather than, forcing the patient for the ear problem and ultimate failure. So this is one of the important, point now in the decision making, that don't ignore the nose before treating the ear. All these major CRS patients have some or other ear problem, and all these, I mean, more than 60% and more than 60% of the major ear issues like cholesteatoma or other things have major nasal problem, and these should not be overlooked to get a better outcome. I said in the beginning about the immunodeficiency. In our practice, up to 5 to 7% of the patient have some or other immunodeficiency. And this is one thing which is most often overlooked. Most often overlooked means you look at the sinuses, look at the CT scan, look at the nasal endoscopy, polyps, and start thinking of surgery. You can get immunoglobulin, all those IgE assay, eosinophilic assay, yet this is overlooked, and this is one of the. If the underlying immunodeficiency is not treated, untreated, you cannot expect a desired outcome, because overall it is immune regulated mechanism which has led to the CRS. So anything which has affected the overall immunity has to be taken care of. Otherwise, your whatever surgery, whatever treatment you is bound to fail. So immunodeficiency could be primary, could be, and nowadays more and more secondary. The diabetes incidence is increasing, organ transplant, so many other immunity disorders are on rise, and we should not overlook all these patients before treating to look into the immune profile of these patients. We have several surprising, immune disorder patients who presented with CRS, and if you don't look at the immune aspect, we don't treat at the immune aspect, you cannot expect a desired outcome. So how come you suspect immunodeficiency? Patient of CRS coming to you, how can you suspect immunodeficiency on those patients? This is something very, very important. When you have a simple infection giving rise to such a major complication, which is surprising complication. For a simple sinusitis, the patient has developed brain abscess. Simple sinusitis patient has developed orbital abscess. You need to look into the immune aspect of the patient, otherwise something you are missing. And if that part is not improved, you cannot expect a good outcome. The patient with unusual progression of the disease, unusual persistent, unusual pathogens on the culture. I remember last month I got a culture sent to me. I got actinomycosis in the culture. We got the immune profile, and that patient has a massive immunodeficiency. And so you cannot ignore such aspect. So you have to be suspicious all the time. If any of these, clinical findings, if you find in your patient, you must look into the immune aspect of the patient to improve the overall outcome. So these are the conditions which gives you suspicion regarding the lower immunity, and this is a workup what we do in our practice. Besides the counts, the cell counts, we do the workup for the immunoglobulins, which are more than 70% of the time responsible for immunodeficiency. Either a single immunoglobulin deficiency or multiple immunoglobulin deficiency, common variable deficiency, or T cell deficiency, which is very common in diabetics. You have seen the condition malignant otitis externa. What is that? Antibiotics, that's the infective conditions, but because of the microvascular disease, the antibiotics are not able to penetrate into the bone. With the bone infection which is given up by the malignant otitis externa, and the antibiotics become ineffective. They become ineffective because of the loss of phagocytic activity of neutrophils, and you can assess by the flow cytometry of the neutrophils and lymphocytes if they have immune dysfunction. Involve your immunologist. Otherwise, whatever treatment we get so many patients being treated for malignant otitis externa for months together with antibiotics and all that. If you look into the immune aspect, they have immune deficiency, and that need to be treated by the immunologist to get a desired outcome. So the same thing is happening here as well for the complement pathway, immunoglobulin pathway, T cell pathway, that if something is happening at the immune level, we must pick up and treat. Otherwise, you'll fall into a failure line. So if there is something like that, our immune deficiency is discovered, start antibiotic on the prophylactic basis, culture directed, vaccination, involve immunologists, immunoglobulin therapy, and so on is required before definitive therapy for the CRS. Otherwise, you keep operating on those patients, and ultimately the desired outcomes are never going to come. So
Sir,
those are the conditions we must look into.
are the immunologists different from infectious disease specialists?
Yeah, immunologists are different. Infectious disease specialists are different. Immunologists are different. It's a different subject. Yes, immunologists are different. Infectious disease specialists are different. Another thing, as I mentioned, which complicates our treatment is the biofilms in certain group of patients. We always talk of biofilms, how they complicate our course. We must understand these are just aggregates of bacterial colonies which secrete a proteoglycan matrix around on the mucosal surfaces, which protects them from the treatment by antibiotic, by immune system, or by anything. And the bacteria, they exist in a different phenotype, in a different mode, and survives all antibacterial and other immunological treatment, and keep on shredding bacteria and giving virulent infections. So biofilms are very, very complex situation. The treatment is very difficult. Diagnosis is very difficult. And there is some defect in the immune system which leads to the development of the biofilms. So how to suspect the biofilms? Number one, we are treating some patient, you are treating infection, you have a culture-directed antibiotic, yet there is no improvement. So you have to suspect biofilms on certain clinical grounds. If you have a patient being treated in spite of the culture-directed antibiotic not improving, because culture is a very poor source of identification of bacteria in a particular, infection. Culture can pick up one or two bacteria. Ideally, you need the, different molecular methods to identify the bacteria, but what is clinically available is the culture. In spite of the culture-directed treatment, if the patient is not improving, culture negatives, in spite of the repeated, clinical setting of the infections, immunocompromised patients are the patients where the biofilms are prevalent. And these are most difficult things to treat, most difficult things to diagnose. And the bacteria which are mostly responsible are either Staph aureus or Pseudomonas. And these conditions are most difficult. And mostly you'll find them in the post-operative setting. You operate on a patient of sinus surgery, raw areas, the conducive environment for the bacteria to grow. And in spite of the various treatment, it is not improving because of the biofilms. And here comes the role of magic drugs, macrolides. Macrolides prevent the biofilm formation. If the biofilm is formed, they break the, prevent the development of this protoglycan shell. It breaks the protoglycan shell and it works at various cells. So all these difficult patients start macrolides, particularly in the sinus disease. If you don't find anything, concrete, you can start macrolides. And there are reasons for the biofilms why the antibiotics are not working, because the shield, the protoglycan shield itself prevents the antibacterial diffusion. It propels the bacteria antibiotics back. And there are many mechanisms by means of which the antibiotics do not work on biofilms. And so you have to develop new strategies. There are many strategies. We work on it to combat the biofilm situation. Many times we see biofilms, and in sinus surgery, these are the ways in our clinical practice we deal with the biofilms. Biofilms are most difficult. We have tried every possible thing, even baby shampoo and all those surfactants to shred off biofilms on the surface, but doesn't work. They have their own deleterious effect. And finally, we have resorted to two things. See, it is very difficult to identify because in clinical practice, there are no methods to detect biofilms. What you can get to know, yes, there are biofilms on the mucosal samples by, by the staining, by the gram staining, you can get to know there are some bacteria on the mucosal surface, and which is in the clinical setting, which is not being treated by the antibiotics with the best available antibiotics, means there are biofilms. Now, there are two options, either Staph aureus or Pseudomonas, which give resistant biofilms. In any of the culture, if Staph aureus comes, we start mupirocin washes. This is the most effective treatment for these biofilms. This is very expensive. Earlier we bought, now we got a new vendor by means of which we are buying mupirocin. Now the present cost of the mupirocin is 3.5 lakh rupees for a kg. Salt of mupirocin, 1 kg salt of mupirocin costs 3.5 lakhs. And the solution of mupirocin, if you have any kind of severe Staph aureus infection, even 2 or 3 washes with topical washes of mupirocin will wash away the biofilms like anything, like magic. And it works like magic. Any severe MRSA or whatever Staph aureus infection, if you use topical mupirocin, it works like magic. Similarly, we use Manuka honey, which we acquire from New Zealand for all these biofilms and difficult wounds and difficult. Irrespective of the culture, the Manuka honey works at every single microbe or any single pathogen on the planet. So Manuka honey is something we acquire from the New Zealand nowadays, and this is very important. You can also acquire online this Manuka honey, and this is the lab approved by the FDA for the medicated Manuka honey. So this is simply honey, like any other honey. This is a special honey produced in a nectar period in the New Zealand on those particular bees, which has a high methyl glyoxyl content. This is something which is lethal to every microbe on the planet. This is something, or any severe infection, use topical Manuka. In the nose, we pack Manuka honey, in the form of packs Manuka honey for 24 hours or so, and it takes away the infection like magic, which is not being treated by any given antibiotic. But these biofilms are not treated with the antibiotic. Even if you use 1,000 times concentration, it doesn't work. And Manuka honey works like a magic, and you can cure these patients very easily. So Manuka honey, sometimes silver, we use silver sprays we tried. We have stopped now because of the irritant effect. But yes, it is good for initial infection. You can use silver sprays. These are available online. You can buy. Probiotics have a big role. I am coming to it as a microbiome concept. And there are a lot of work is going on targeting things. So Pseudomonas infection, mainly in the nose, if you get 100 times culture, 95% of the time you'll get Staph aureus as a virulent organism, if there is virulent infection. Only in rare situations, Pseudomonas you will get. So never directly any antibiotic directing Pseudomonas. This is very important because we have to give antibiotics sometimes in the post-operative setting or any setting. We rarely give antibiotics directing Pseudomonas except in these conditions, which is mostly either diabetic patient, immunocompromised patient, cystic fibrosis patient, or revision cases where the Pseudomonas biofilms are common, because that gives you a conducive atmosphere for the Pseudomonas to grow. And in those situations, you have to direct the treatment according to Pseudomonas. These are silver sinus sprays which are available online, and they work very well. They are very, very effective, cost effective as well, and you can use in certain situations. Osteitis. This is another severe form of disease. Probably we have a case tomorrow. See this kind of osteitis. What is osteitis? Until now, what we have been discussing is the mucosal inflammation. This is inflammation which has gone beyond the mucosa to involve the bone as well, directly or indirectly. Indirectly by means of neo-osteogenesis or something, or directly by means of infiltrating the bone. So bone becomes the depot of these inflammatory cytokines, and whatever times you operate these patients, then they're not going to work unless you remove the underlying bone. And that is one of the most difficult aspects, as it preferentially involves the ethmoid septations, and you have to radically remove these. Radically means if you leave the bone, you're leaving the cytokine depot inside. Your steroids are not going to work. Topical steroids have their limitation to penetrate there, and the disease is going to come back again and again. And these are the most difficult patients to treat unless you remove all these bones radically containing all these cytokines there as a depot. So macrolide again has a big role, as they prevent the fibroblast turning into osteoblast and prevent this kind of osteitis formation. Most of these patients with osteitis almost always have biofilms. Biofilm induces severe aspect of the disease, bringing in more cytokines, more eosinophilic, and more that kind of material to give a severe aspect of the disease. So this is another severe aspect of the disease. If you come across a situation, must be prepared to deal with more extensive, treatments. As far as therapies we discussed, we have limited, armamentarium as far as the medical treatment is concerned. But there are lots of, treatment you must have seen in the prescription. People have a habit of giving antifungal, habit of giving mucolytics, decongestant, antihistamine. None of these have any role practically on the management of CRS. CRS, as we have discussed, is an inflammatory disease driven by certain cytokines. And antihistamine, decongestant, they have hardly any role. No role. Then now what new drugs have come in which can be used in adjuvant drug therapy? This is something to discuss. Those adjuvant therapies, which can help improve our overall outcome as far as the medical treatment is concerned, because by and large, we have only steroid as an important medical treatment in our basket so far. So other drugs like antihistamines are reserved to control the symptoms of allergy, not for CRS. What I mean to say, antihistamine means they competitively bind to the histamine receptor. Now, where does the histamine come from? By means of allergen. When the allergic reaction happens, it binds to the IgE. IgE degranulates the mast cells, and mast cell releases histamine, and that histamine release in the circulation gives symptoms. Antihistamines, by competitively attaching to the or blocking the histamine receptor, makes the histamine not binding to the antihistamine receptor, and you can treat the symptoms of allergic rhinitis. That's it. It has no role in the overall management of allergic rhinitis, doesn't modify the course of allergic rhinitis, just treat the symptomatology of allergic rhinitis by means of competitively binding the histamine receptor, which is making the histamine receptor not available for the antihistamine, for the histamine to bind. That's the role of antihistamine. Leukotrienes have a big role in AERD and in lower airways, not in regular CRS. And immunotherapy obviously has a main role in allergic rhinitis. The only treatment in allergic rhinitis which can modify the course of allergic rhinitis is immunotherapy. So all those patients having allergy, must be subjected to skin prick testing and desired immunotherapy for that. So these otherwise have no role in clinical practice to bring in all these drugs for any treatment. Antifungals, hardly any role, as I've already mentioned, except in certain situations when you have impending complication, you have a severe, fungal disease. Like we have a patient today who developed, slight vision loss day before, and we have kept on antifungal and steroid for today. To buy the time to reduce the inflammatory load, you can use all those patients and antifungal. Otherwise, hardly any role in post-operative situations. Also, sometimes in diabetic patient where you can't use oral steroids and all that. In steroid-resistant cases, sometimes as a rescue treatment, you can use antifungals. Otherwise, antifungals have hardly any role. There is no point in prescribing antifungal for non-invasive sinusitis or any kind of fungal sinusitis. Now, what can be instituted as an adjuvant therapy in the recent time, what we have discovered from this literature? And this has become a important part of our prescription nowadays. Our prescription doesn't contain any of these for the CRS management by and large. Our prescription contains now which are the drugs which modifies the immune system, which has an impact on improving the overall immunity, which has an impact on improving the sinonasal immunity, and which should be the part of the prescription now. So microbiome, to understand this, we need to understand the human microbiome. Human microbiome means, our body contains more bacteria than the human cells. We have 10 times bacteria than human cells. For each human cell, we have 10 bacteria in our body, and most of them are residing in the intestine. Trillions and trillions of bacteria. Those are good bacteria which are in, constant relationship with the body to maintain the homeostasis. Anything which improves the bacterial symbiosis or bacterial, numbers, in terms of diversity, in terms of evenness, the various species of bacteria, anything which improves has a positive impact on the overall immunity as well as sinonasal immunity. So there are certain drugs which has an effect on improving the microbiome, has an overall impact on improving the overall immunity. Antibiotics, whenever you use, we must not use broad spectrum antibiotic. There has been, the trend using broad spectrum antibiotic covering any infection coming in the vicinity will be taken care of. We should use narrow spectrum antibiotic. We should not suppress the good bacteria. We have to suppress the pathogenic bacteria, not the good bacteria, and we should use narrow spectrum culture directed antibiotic rather than broad spectrum antibiotic. If you reduce the good bacteria, the immunity will suppress and the overall results will be poor. So all those things which have a deleterious effect on microbiome composition, which is basically formed in the infancy by means of lots of issues. Recently a study was done on so many things. The studies are done on the birth process. Those who have vaginal delivery, those children who have a cesarean delivery have a different microbiome, because the microbiome which child acquires during the birth process is who is exposed to the microbiome during the birth process has a significant impact on numbers of good bacteria in the intestine, and those have a good immunity, overall good immunity as compared to the cesarean delivered children. So this microbiome is formed in the initial first year of life. It is affected by lots of diet and other factors, by nutritional factor, by environmental factor, so many other factors, and this can be modulated. So now the present concept is to improve the immunity by means of modulating the microbiome. So those drugs which have a effect on improving the microbiome should be included in the prescription to improve the overall immunity, and those are probiotics, prebiotics, and postbiotics. Probiotics we give in the prescription as a live bacterium. In numbers, in billions of probiotics we give, which add on to the good bacteria in the intestine and improve the overall, immunity. Prebiotics are basically non-digestible material for the bacteria to, as a substrate for the bacteria to grow, and that improve the concentration of good bacteria. So it is, prebiotic is not bacteria but a non-digestible concentrate as a good substrate for the bacteria to grow, and increases the concentration of good bacteria. Postbiotics are bacterial substrates which has an impact on the immunity, and these three things have a overall good impact on the immunity. Overall immunity, not only overall immunity, but the cyanonasal immunity also. So probiotics have been proven to have lots of effect on the immune system by exerting various mechanisms. And even in the cyanonasal system, they have a huge impact on improving the overall immunity. And we must include probiotics in our, in our overall treatment once we think of improving the immunity by various means. And the probiotics is one of the major ways. We have seen the cascade and it improved, it works at the various level of the cascade to improve the overall inflammation. Postbiotics are non-viable, and one of them is been very popular, the Bronchovaxone. We know the OM85. This is basically the bacterial lysate of 8 common bacteria. These are the end protects metabolites of the bacteria, which has an good impact on the immune system. And these are the future. These are the future. And we have now a policy to include them in our prescription to improve the overall immunity, to prevent recurrent infection, to improve the overall immune conditions. It improves the innate immunity, adaptive immunity, every level by various mechanisms, and should be included in the prescription to improve the overall status, because they work by various level at the molecular level to improve the overall immunity. Another drug which has been again described as a wonder drug to improve the immunity as an immunostimulant is pidotimod. Not only for infection, for allergy, for many things, it works at the molecular level to improve the immunity. And these are the drugs should be part of our prescriptions for the, overall all these immune disorders when we think of managing these immune disorders. So they decrease the repeated infection by various means. They decrease the modulate the immunity by various means. They have an anti-allergic effect by various means, including reduction of the Ig and various things. And this should be given as a 2-month treatment. Is approved for the children as well as result, and an amazing effect on the overall immunity, particularly in children, like all those adenoid patients treated, having all repeated adenoid, allergy, immunity, infection, so many things. And these are the good candidates for pidotimod as a primary treatment to improve the overall immunity. So these are the drugs, possible drugs, which can modulate the immune system and improve the immune system. So beside the steroid, these are the things which can be used in a, adjuvant therapy rather than antihistamine, all those things are not required. These are the drugs which modulate the immune system. Anything which modulate, these are all antioxidant. Besides their anti-inflammatory, anti-mucolytic activity, these are strong antioxidant. Resveratrol is one of the strongest, antioxidants on the planet after nanocurcumin. Resveratrol is found in red grapes, and the highest concentration is in the red wine, more than the red grapes, because it is more concentrated there. And this is one of the, I would say, after the nanocurcumin, one of the strongest antioxidant, and has been reserved and proven in the American literature as an anti-cancer drug, as it works at the, various receptor level to prevent the cancer formation and block the cancer forming pathways. So similarly here, it has an inflammatory effect in the sinonasal cavity also. And particularly we use in cystic fibrosis patient from day one, as it has a lot of effect. In AERD also, it has a big effect by means of reducing the interleukin level. So resveratrol is one of the, I would say, adjuvant therapy, which we can consider, as an adjuvant therapy for various pathologies. What is the time you are going to take break? Alchem, anybody from Alchem? There was a tea break supposed to be. Anybody? Nobody from the Alchem here? What time is the tea break? Will you please let me know? We have a 10 minutes tea break. We can take any time. Because now this is a very important part of the section before we start the live surgery in the afternoon. Understanding various endotypes of CRS. CRS not a single disease. The disease with huge wide spectrum. And now is the time of precision medicine. Every disease endotype has a different underlying pathophysiological process. And there are variety of endotypes. If we reach to the diagnosis of particular endotype, we can tailor our therapy accordingly. We can tailor our surgical treatment accordingly. We can tailor the extent of surgery accordingly, and we can tailor or find the need of biologics accordingly in those cases for the particular endotype. So these are basically reserved for the severe CRS, type 2 CRS or eosinophilic driven CRS. So how to pick up those patients? What are the candidates of difficult, therapy, difficult treatment, which need a lot of other adjuvant therapies and biologic therapies and all that? These are the patients with bilateral polyp with allergies. They have taken or needing more and more steroids for the treatment, comorbid asthma, earlier history of surgery, severe tissue eosinophilia, have loss of smell. Loss of smell is one of the symptom signifies severe disease or signifies eosinophilic disease. Why I'm saying so? Loss of symptom smell can be because of two reasons. One is conductive loss. We have polyps and it blocks the air to reach the olfactory receptor and the patient doesn't perceive the olfaction. You remove the polyp, it improves. Second is because of the inflammation. And loss of smell, which doesn't improve so easily, is mostly because of eosinophilic toxin activity, which affects the olfactory mucosa. Eosinophilic toxins have deleterious effect on the mucosa. What time? Ready? So next, after this slide, we'll have a tea break and then we'll reassemble. So eosinophilic toxins have a deleterious effect on olfaction, and those are the patients who are difficult patients, who have more severe disease, more severe inflammatory profile, and they need a severe treatment, extensive treatment for that. So these are the tests to identify severe disease patients. And accordingly, we have to target those patients. So there are variety of endotypes, and each endotype has a different underlying pathophysiology. Each requires a different treatment, different post-surgery treatment. Like AFRS is pure allergic, which require post-surgery, steroid therapy, oral as well as topical steroid therapy. Since the allergy is the cause, it requires post-therapy, immunotherapy, allergic testing and immunotherapy. AERD is a different because of the aspirin sensitivity, because of the COX-1 inhibition, the leukotrienes are overproduced and you need anti-leukotriene therapy, aspirin desensitization. Presentation of all these patients is same polyps, but the underlying pathophysiology is different. If these patients are not desensitized, you can treat 100 times, they are going to come back. So every endotype has a different pathophysiology. Cystic fibrosis has a different pathophysiology. Odontogenic sinusitis has a different pathophysiology. Pediatric sinusitis is a different pathophysiology. You can't treat all these on the same line of steroid treatment or same line of surgical treatment. The extent of surgery is different kind of patients, and the post-operative treatment is different. So we will now discuss the endotypes of CRS after the break. Thank you so much for your attention.
क्या नाम है उसका?
So, to carry forward this discussion about CRS, we move on to this very important aspect of understanding various CRS endotypes. As I said, CRS is not a single disease. It is a multifactorial disease, and various endotypes have various underlying pathophysiological processes. We need to pick up and diagnose a particular endotype so that we can direct or tailor our therapy according to that to get the best results. Like, for example, if we go one by one of the commonest endotype is allergic fungal rhinosinusitis. As the name implies, the etiology is allergy. Earlier was a discussion, can allergy contribute to CRS formation? And this is a live example. This is mainly because of allergy to some fungal antigen. We are exposed to fungus, which is ubiquitous in the air. And if inhaled fungus happens to get trapped in one of the sinuses, and if person is allergic to that particular fungus, then the body's immune response creates this kind of phenomena. This is purely over immune response by the body to some fungal antigen which the person is allergic to. And moment the fungus is trapped in the sinus, the eosinophilic activity comes into action, and this entire phenomena is produced by the eosinophils, which secrete a lot of mucus, a lot of toxins, cytokines around the fungus, and give this classical picture of this allergic fungal rhinosinusitis. So start with your voice. This is a classical picture of allergic fungal sinusitis, which is defined as one of the criteria by the Banto-Kuhn for diagnosis of this disease. So this is pure allergic, where the fungus is trapped and the eosinophil comes around because of the allergy to that fungus. And this classical picture with fungus in the middle and all around allergic mucin, blocking the sinus, expansion of the sinus because of the non-drainage of the sinus, because of the blockage of the mucociliary activity, and this vicious cycle starts and gives this kind of a terrific bony erosions all around, and this kind of a picture which looks like an invasive fungus, which is actually not an invasive fungus. It is not invading the mucosa. It is because of the volume of the material, the fungus and the surrounding mucin, which is giving rise to this kind of a picture. And that these patients have classic nasal polyposis. Most of the time, these patients are young patients. They are not immunocompromised. Mostly disease to begin with is unilateral, and then it can become bilateral as well. And there is always a controversy, if there is unilateral, we need to treat bilateral or not. There is never a treatment for, the treatment is not required for uninvolved side, as nowadays we give post-operative irrigation to prevent disease coming to the other side. And there are lots of fungus, particularly aspergillus, which is involved in the causation. And this kind of a picture, this is pure allergic, and this requires a dedicated treatment. This is one of the common endotypes. We have the first case today. We have posted is a allergic fungal rhinosinusitis in a child, unilateral disease. This disease, where the fungus is acting as an antigen, is a pure surgical entity. See, you will see all these endotypes have a different pathophysiologic process which is underlying and requires a different treatment. For this particular endotype, there is no role of medical treatment because fungus is acting as an antigen and we need to remove antigen. The moment we diagnose this disease, there is no point in wasting time for the medical treatment. There is no maximum or adequate medical management for this. The only treatment is surgical. This is pure surgical entity, and the aim of surgery is multi-pronged. The main aim is to remove this allergic fungal material. The fungus which is trapped in the mucin, along with the mucin, everything has to be extracted out, removed, and give wide openings. Since this is a pure type 1 hypersensitivity, like any other type 1 hypersensitivity phenomena or pathology, steroid is the answer. And for this problem, steroid is the mainstay of treatment. Post-operatively, as we give the wide opening, which gives good introduction of the steroid deep into the sinuses. So steroid should be introduced deep into the sinuses post-operatively, which is the mainstay of treatment. And that's why in surgery also, this is one disease where we need to give mega openings. See, in every endotype, according to the requirement of the post-operative treatment, we have to choose our surgical extent as well. In this particular patient, we have to give mega enterostomies because they need lifelong surveillance. The patient is always allergic. Once he is allergic, he is always allergic unless it is cured by the post-operative immunotherapy. So all these patients being allergic, they require post-operative immunotherapy as well as, and we give after 2-3 months, we get skin prick testing done, and accordingly, whatever fungal alternaria or something which requires an immunotherapy, and that is the only cure for these patients. Otherwise, they require long-term or even lifelong steroid rinses, because the moment you stop, again the fungus can get trapped and again the same phenomena can start. So they have a high recurrence unless they are followed up along with a long-term steroid therapy and long-term surveillance. And in order to do long-term surveillance and introduce the steroids, we need to create wide enterostomies. So these are the classical allergic fungal rhinosinusitis patients, and they require this kind of a full house fest for the reasons I mentioned, and we use hydrodebrider. This is the only condition where the hydrodebrider is a value, has a big role. Hydrodebrider is nothing but a water jet attached to the debrider. So that water jet, which has the ability to rotate 360 degree, can flush this entire antigenic material 360 degree from the sinuses. The reason being, if you leave the fungus behind, leave this antigenic material behind, the same phenomena will come back, and whatever you have done can result into failure. So you have to remove each and every bit of fungal material which is actually acting as an antigen. So this is a particular endotype which requires a particular kind of therapy, and post-operatively irrigation and immunotherapy, and practically no role of antifungals. There is always a confusion by people to start antifungal for these patients. Practically, there is no role of antifungal in this. This is non-invasive disease. Fungus, antifungal has some role in situation post-operatively in recurrences, diabetic patient where oral fungal cannot be given, as a oral steroid cannot be given. Antifungal is given as a rescue treatment for the steroids. So that's the only place for the antifungals in these diseases. Otherwise, steroid is the treatment of choice. So this is allergic fungal rhinosinusitis. Anybody has any doubts, any query, or any suggestion, please feel free to interrupt me any point of time. This second endotype is aspirin exaggerated respiratory disease. If we see the spectrum of CRS from the lowest to the highest level of inflammatory spectrum, AERD is the highest inflammatory spectrum, which gives highest inflammation because of the massive leukotriene formation. And we need to understand this pathophysiology so that we can accordingly direct our treatment to the pathologic process which is going on, which has led to this kind of AERD. So AERD is what? Aspirin exaggerated respiratory disease. These are patients who have nasal polyposis and asthma and have associated hypersensitivity to the COX-1 inhibitors, aspirin and other COX-1 inhibitors. So the moment you give COX-1 inhibitor to these patients, what happens normally? See what is happening at the molecular level. Normally, when our cells degrades, the arachnoid acid in the cells is degraded by the cyclooxygenase enzyme to the prostaglandin, which are anti-inflammatory agent. Since it is a COX-1 inhibitor and the patient is sensitive to it, the cyclooxygenase activity is aborted and these prostaglandins are not formed, which leads to stimulation of lipoxygenase pathway, which leads to abundance of leukotriene formation. More leukotriene receptors, more leukotriene formation happens to occur, and leukotrienes are massive allergic or inflammatory drivers. And leukotriene formation once happens to occur, they lead to various activities on the mucosa, on the mucous gland, mucosa. They bring in lots of cytokines, TS2 cytokines, IL-5, IF-13, eosinophil, they activate mast cell, basophils, and create the highest level of, inflammatory process, they orchestra in the entire epithelium, not only sinonasal, but the lower airway as well. And this gives the highest spectrum of inflammatory disease which present as a nasal polyp. Now, if you are unaware of that kind of nasal polyp with this kind of underlying pathophysiology, whatever surgery you do, it is going to go waste unless this pathologic process is completely taken care of. We need to stop this pathway of leukotriene formation. Otherwise, whatever number of time you operate, the patient is going to come back. And these patients, because of the massive leukotriene infiltration, have a particular hyperplastic mucosa. When you are operating on a AERD, you can, by feel of mucosa, you can diagnose that this is a patient of AERD. They have a thick hyperplastic mucosa as compared to the other polypo patients. So, how can you diagnose these patients? Any patient who is having polyposis, having asthma, the guidelines are to test for the aspirin if they are sensitive. So all patients of polyps and asthma must be tested for aspirin sensitivity. They have a, massive inflammatory level at the mucosal level because of all these cytokines, particularly leukotrienes, which formed in abundance. And the treatment is directed at the inflammatory process. Directed at the inflammatory process means the thing which works maximum at the underlying inflammatory pathology, steroid again. So you have to do full house fast and introduce high doses of steroids since the eosinophils are in abundance. This is one of the endotype which has the highest eosinophil count in the mucosa, and we have to give long courses of steroids, oral and sometimes, in between oral along with the topical steroid. And for the steroid to introduce in these patients deep into the mucosa, deep into the sinuses, all these patients require biggest sinusotomies. All these patients primarily require a draft 3. Open up all frontal sinus floor completely for the, steroid to go deep into the sinuses. All AERD patients primarily require a draft 3, primarily require a mega middle meatal enterostomy, primarily require a mega sphenoid sinusotomy, a sort of nasalization procedure where you can introduce the steroid uninhibited deep into the sinuses because they represent the highest inflammatory spectrum. So again, every endotype directs a different kind of surgical treatment as well. Like AERD, this is a more inflammatory process, more severe inflammation, and this requires a bigger sinusotomies for steroid to introduce into the deep into the sinus. As far as the medical treatment is concerned, if you look at the pathway of pathogenesis, say this, the lipoxygenase is stimulated to form the leukotrienes, and leukotrienes act on the leukotriene receptors, and similarly the treatment is directed to block the 5-lipoxygenase by means of xylitol. Xylitol is not available in India, but we have acquired twice for a patient from abroad. There's a very expensive drug. And secondly, the leukotriene receptor inhibitors, which are quite common in practice, that is Montelukast and all, and that is very important to competitively inhibit the leukotrienes to act on the leukotriene receptors, because the leukotrienes are formed in abundance as well as the leukotriene receptors, and the Montelukast has a big role. This is one endotype where the Montelukast has a key role. Otherwise, there is no point in giving Montelukast for any CRS patient. This is such an important understanding of endotyping. Every endotype has a different pathophysiology process, and this endotype requires Montelukast as a key treatment, key medical treatment, post-operative treatment. And all those diets, salicylate diets, and all those which forms leukotriene formation, which favors leukotriene formation, should be avoided. This is one endotype. If the patient drinks alcohol, he'll show severe reaction like takes aspirin, because the alcohol inhibits the leukotriene degradation, and the patient develops within half an hour or hour a severe reaction like the intake of the aspirin, Like aspirin, the patient is sensitive to aspirin. The same kind of reaction is exhibited by intake of the alcohol. And this is one of the ways so many times these patients are, they present and they are diagnosed. They are severely, allergic to alcohol as it precipitates the aspirin-like reaction in those patients. So for the improvement, the salicylate diet means all those dry fruits, spices, all should be avoided to prevent leukotriene formation. Alcohol should be avoided, and resveratrol as a key drug. This is one place where we use from day one all these patients resveratrol, which inhibits 5-lipoxygenase as well as leukotriene formation. So this is a very, very important endotype. Now we have more than 400 patients wherein we have desensitized with the aspirin. This is one pathology which requires the reversal of the same pathophysiology, what it has started with. The pathophysiology started with the cyclooxygenase blockage and lipoxygenase abundance, and the same pathophysiology should be reversed, and that is possible by means of aspirin desensitization. And these patients should be thoroughly convinced for the aspirin desensitization, which should take place after the surgery, because you have to start aspirin in those patients, so it has to be done after the surgery. Otherwise, you cannot operate upon those patients. And once the inflammatory load is minimum, that time the desensitization should be taken place. So our ideal point for desensitization is couple of weeks after the surgery, once the mucosa heals and all that. As far as the painkillers are concerned, since the COX-1 has a reaction, COX-1 precipitates this entire reaction. As far as painkillers are concerned, the COX-2 inhibitors can be given, atorecoxib, celecoxib can be safely given to these patients. Even the paracetamol can, stimulate the same kind of reaction in high doses. So we should avoid all these. Only atorecoxib is one of the best drugs as a painkiller for these patients. So aspirin desensitization has a key role to treat these patients. Otherwise, any number of times you can operate, they are going to come back, because the underlying pathophysiology is leukotriene formation, and that has to be reversed. And that can be reversed in the same way that the patient is sensitized to the aspirin, it has to be desensitized to the aspirin. And that aspirin desensitization is a key method. It can be risky. It has to be done in a dedicated setup. And we have a tie-up for this with our intensive care unit, with the pulmonologist. Whenever we do these patients, we have to counsel a lot, because it's a very, very tedious process which can precipitate a severe bronchospasm or any kind of reaction, which is a hallmark of this pathology, because you have to give aspirin to those patients. So first of all, many times the question comes to the diagnosis. Like somebody asked me just now, how you diagnose these patients. So you can diagnose by the history. All polyp patients having asthma must be thoroughly assessed. If the patient many a time give history that he is allergic to painkillers, otherwise, even if he gives history, you have to test, and we do SPT, skin prick testing. There are many ways otherwise to test this aspirin sensitivity. You can give oral aspirin, but that is very, very risky. It can be given in the ICU setting, because the patient can develop a bronchospasm, severe bronchospasm. Can be given with a inhalant aspirin, or can be tested by a blood test. Nowadays, we are getting that test done. That is the best way. Even you don't have to do SPT. Since leukotrienes are formed in abundance, we get urinary leukotriene levels done. And in these patients, they have significantly elevated urinary leukotrienes, which are not elevated in any other kind of CRS or any other pathology. So by simple blood test of elevated urinary leukotriene, you can diagnose this disease without doing any other test. That's the simplest way of diagnosis this disease. And once you diagnose this, even if you operate such patients, you have to tell them this is the most difficult condition. Your surgery need to be revised if you don't desensitize. And when surgery is taken, it has to be mega enterostomies. This is, the key concept of surgery in AERD patients. Bilateral draft 3, bilateral sort of medial maxillectomy, nasalization kind of surgery, which gives a sort of, a deeper penetration of topical steroid when you introduce. So once you diagnose with the aspirin challenge test, desensitization is a process where you need to admit the patient in the ICU for 2 to 3 days. And we do with our pulmonologists. There are criteria for desensitization. You have to block the severe reaction once you start aspirin. For desensitization, you have to start oral aspirin directly, which the patient is sensitive to, and it can precipitate even the status asthmaticus. So you have to prime the patient of desensitization process. You have to start Montelukast a week before to blunt the process of to blunt the reaction of the desensitization process, the reaction of the aspirin, and you have to test with a basic force expiratory volume. It should not be very low. So the patient can sustain the bronchospasm, whatever happens to occur, or minimal bronchospasm with that. It should be done in ICU setting. And how it is done, there are many protocols. We do a 3-day protocol, 2 days and 1 day extra stay. Means you have to start with a low dose of aspirin. We start with a 30 milligram. Reaction is bound to happen. With a minimal 30 milligram, you have to be ready with all the measures for the nasal and the bronchial reaction with oral steroid, or even the epinephrine injection, whatever, and control it. And the moment once it is controlled, after 3 hours, you have to raise the drug from 30 milligram to 60 milligram, then to 90 milligram every 3 hours, and the patient becomes, start sustaining the aspirin very well without reaction. That is the classic, phenomena of this aspirin tolerance, which happens to start after the increasing doses of aspirin. Once the patient start tolerating aspirin, next day you can raise to 150, 200, 300 milligram. In 2 days time, we bring it to 325 milligram. Once patient starts tolerating 325, you can further raise to 650 or whatever. But the moment patient starts tolerating aspirin, prostaglandin starts forming, leukotriene stop forming, and the entire pathophysiology is reversed. So this is the classic of aspirin desensitization. When the patient starts tolerating aspirin, when the patient start tolerating aspirin, the entire pathophysiology is reversed. You don't need to operate these patients again and again. What all is required, the challenge is to sustain the aspirin for life, because these patients require aspirin for life. Many times we come across young patients. The last patient we did, I saw him yesterday, was operated 1 year before, had 17 surgery done earlier without the diagnosis of AERD. 17 times he was operated, then came with, we operated again, sensitization. This has been 1 year now. He's on aspirin. We have reduced to almost half the dose we started. Now he's on 150 milligram a day and doing well. Absolutely normal, healthy mucosa. And that is what we require. So this is a very classical, endotype of ARD, which requires a dedicated treatment. So every polyp patient has a different endotype. We need to reach to the correct pathophysiological process to revert it or address it accordingly. So this is aspirin sensitization, which is very important. Though it is contraindicated in certain settings, it cannot be done in all patients, particularly children, pregnant ladies, patients who have uncontrolled, unstable asthma. So severe asthmatic patient, you cannot take a chance of giving aspirin to, precipitate status asthmaticus, and those are the most difficult patients. Patient already having aspirin problems like gastric ulcers, having bleeding disorders, and many other complications of aspirin already happening. And these are the patients, you are not left with any other choice but to give biologics. These are the classic indications for monoclonal antibodies, where you cannot desensitize the patient with the aspirin. So these are the classic indication. Otherwise, you either keep giving oral steroid or keep operating. You are not left with any other choice but to either desensitize or giving biological therapy. So these are the indications of biologics in the AERD patients, either those patients where it is not possible, or where it is contraindicated, or patient, in spite of the desensitization, they are not responding well. There are certain group of patients even not responding to aspirin. And many times such patient we desensitize with the ibuprofen and sustain on ibuprofen. Ibuprofen is a good aspirin-like action, and it is a good drug. 2 of our patients, we have switched from aspirin to ibuprofen and doing well. So this is some time we can try. And those patients where you cannot operate again and again, you cannot do aspirin sensitization, these are the patients for biologics. They are most difficult category of patients, AERD patients, and we must be careful before treating these patients very much. Any questions? Then we move on to the next endotype. This is central compartment atopic disease, the newly introduced endotype. There's a where we have a case probably tomorrow. This is again allergic. It's an allergic etiology. Why it is happening? When we inhale, if the patient is allergic to certain particles, when we inhale the air, the arc of air goes like that above the inferior turbinate, then towards the midline, towards the middle turbinate, posterior superior part of the nasal septum, and superior turbinate, then goes down towards the nasopharynx. So that when we inhale, the arc of air goes like this. Patient who is allergic, those particles are deposited in the central part of the nose. And central part means posterior superior part of the nasal septum, middle turbinate and superior turbinate, which actually act as a filter to prevent these particles going to the lower airway. So that is the area of central compartment where the disease starts. This is the kind of picture where the lateral compartment is free. Lateral sinuses are free, though it can progress, the disease ultimately progresses to involve and block the ostium of the lateral sinuses and involve everything. Otherwise, to begin with, the disease starts in the central compartment and then keep on progressing laterally to involve the lateral compartment, and sometimes it becomes a complete whiteout. So this is a central compartment disease where the allergic phenomena is the main role. Starting disease, polyps in the central compartment and progressing in the periphery. This is classical of CCAD, and allergy is the main cause of this disease. And since the disease affects the central compartment and involve the inflammation early in the course, involve the median part of the olfaction, many of these patients primarily present with the olfaction loss. Though the olfaction loss is not that severe like any other eosinophilic sinusitis, and most of the times these patients we have seen in the skin prick testing almost always are dust mite allergic, because perennial dust mite allergy, which is giving constant exposure to these allergens all the time throughout the year, leads to this kind of problem in the central part of the nasal cavity or the sinonasal compartment. So it's a localized inflammatory response in the central sinonasal compartment, which is exposed to the inhaled and ambient air. And the treatment is very, very simple. Out of all endotypes, this is the most favorable outcome, because you need to treat the central compartment and open up the sinuses all around. All sinuses have normal mucosa. They are not affected by any inflammatory process. The inflammatory process is directed to the central part, and then follow up with the post-operative steroid irrigation and allergen immunotherapy. These are the candidates for pure allergen immunotherapy, and they have the best outcome as compared to the previous two endotypes, the AERD and other endotypes. So central compartment atopic disease is a favorable disease, requires a proper diagnosis. You have to be vigilant, and once you put the endoscope, you will see the polyps in the central compartment over the middle turbinate, posterior superior part of the septum, and then progressing laterally. So these are classical patients of CCAD, and they are the good candidates for surgery and post-operative treatment in immunotherapy. Another endotype, which is mostly overlooked, not uncommon, this is non-polypoidal sinusitis. And this is very interesting, as most of the time we miss this, the dentist miss this, and patient, present later on. This is odontogenic sinusitis. Sometimes the diagnosis is straightforward. Patient has a problem and a sinus problem along, and you put an endoscope and you see the purulent discharge in the middle meatus, and get a CT scan done, and with a complete opacification of the ipsilateral maxillary sinus, because it starts with the maxillary sinus, in the floor of which are the molars and premolars. So it begins as a unilateral maxillary sinus disease with a dental disease in background and present as a sinusitis, and this is classic odontogenic sinusitis. And how you be suspicious about this? In all unilateral maxillary sinusitis patient, particularly presenting with a purulence or classical odontogenic patient, and that that purulence is foul smell, because mostly it is anaerobes which are involved in the pathogenesis of this kind of sinusitis because of the dental cause. And there is history of dental treatment, sometime overlooked. Rather than the regular CT scan, we must get a cone beam CT scan done to see the dental, underlying, dental details, because the regular CT scan doesn't give the fine details of the, underlying dental pathology, which is best picked up by the cone beam CT scan. And cone beam will exactly tell you what is going on to the underlying, dental region. There could be periapical erosion. Most of the time, periapical or, pulpal disease, and you'll see the tooth projecting inside, the periapical, ligament missing, and the disease directly the bursting from the periapical region into the sinuses. So this is a different disease. We have to be very cautious in unilateral patients presenting with many maxillary disease, and then it further progresses to involve the ethmoids and further on. But to begin with, it is maxillary, and most of the time it is periodontal or endodontic disease, sometimes associated with oroventral fistula. Then the diagnosis is very obvious without any doubts. And sometimes post-dental implants as a foreign body, which acts as a foreign body and can start the inflammation. So that is very complex in those situations to treat with. So odontogenic sinusitis, for the diagnosis, unilateral foul smelling with purulence in the middle meatus. Get a culture, you will find anaerobes, and that establishes the diagnosis. So the treatment is an infective pathology. So treatment is obviously antibiotics, but in the presence of the dental disease, the antibiotics generally do not work. So you need to treat the cause, the dental disease. You have to diagnose the dental disease. You have to refer to the dentist, take the dentist's opinion, confirm the dental disease, and then according to the predominance, you have to treat. If the sinusitis is the predominant problem, you have to treat sinuses first and establish the ventilation and drainage, followed by the dental treatment. If the dental disease is prominent, obviously you have to treat the dental first, or sometimes both together. The sinus surgery and the dental work both together can be done. In cases of implants, the implant is a big problem, acting as a foreign body, and many times foreign body infection in the vicinity of the foreign body requires foreign body removal. But here, if the implant is not mobile, it is still fixed, and there is not infection around the implant, still you can try a FS and save the implant many times. Otherwise, you have to explant that, prosthesis to give a cure from the infectious disease to these patients. So this is a very important, type of sinusitis, which is mostly overlooked, which is treatable. It has a perfect cure. This is the only type of sinusitis which we can say has a perfect cure as compared to the other one, but has to be diagnosed and treated properly. This is one of the most difficult one, deadly kind of sinusitis, particularly in children, cystic fibrosis, where the very young children present with bilateral nasal polyposis. The youngest one we have operated is 1.5-year-old, bilateral massive nasal polyposis. And this is a different endotype in terms of certain different characteristics, because it has a genetic problem behind, where there is a mutation in a gene, cystic fibrosis, transconductor gene, which leads to thick viscid secretion because of defective chloride transport. So the problem is genetic, which manifests in the nose because of impaired mucociliary activity. The secretions become thick and viscid, and the sinus clearance doesn't take place so easily. And that the redundant secretions in the sinuses, the stagnant secretion, inviting infection, giving this kind of a problem. And these young children, poor children, they develop, because the same problem happens in the lower airway, and they have concomitant lower airway infections as well because of the impaired mucociliary activity. And because of the nasal infection, the lower airway infections, exaggerate, and mostly they have a limited lifespan, but ultimately these patients require lung transplantation because of the repeated lower airway infection. And it is the upper airway infection which is deadly, which is responsible for lower airway problem. Even after the post-transplant, the cause of death in all these patients is upper airway infection. So these patients have a limited lifespan, and their entire lifespan evolves around control of infection in the upper airway. This is not eosinophilic disease, unlike other endotypes of sinusitis. This is a pure neutrophilic driven disease, pure infective disease because of stagnant secretions. And the infection in this particular problem is almost always because of Pseudomonas. And what we can give besides the medical treatment, there are lots of, nowadays this drug modifiers are available, modifying this gene. Gene modifiers therapy is available, very, very costly gene modified therapy, but yes, still it is available. But for the nasal treatment, what best we can do is a hypertonic saline rinses. See, we can use, normally we use in our sinus disease or post-surgery or whatever, isotonic saline. This is one place where the hypertonic saline is indicated because the ciliary activity is not working and you have to really need something mechanically to bring out all the secretions. So hypertonic saline, wide, enterostomies to give gravitational drainage as the ciliary activity is not happening. See, the infection is because of stagnant secretion. So the goal is to open up all wide sinus. The youngest child we have done bilateral medial maxillectomy is 1.5-year-old to give gravitational drainage and to introduce topical antibiotics. In other endotypes of sinusitis, which is driven by the eosinophil, we introduce steroids. Here, steroids have hardly any role. It is the infection where the topical antibiotics have a big role. Since Pseudomonas is the predominant pathogen, almost always the tobramycin washes are the mainstay of treatment post-operatively. So gravitational drainage, nasalization, remove everything. Fortunately, in young children, the frontal sinuses and sphenoids are not developed. It is on the maxillary and the ethmoids, and you can do a bilateral medial maxillectomy, remove the middle turbinates, and a sort of nasalization procedure for the gravitational drainage, and then introducing topical tobramycin and other hypertonic saline and all those things. Mucolytics, yes, strong mucolytics are required, like Dornase alpha is the strongest mucolytics, which is, clears the degraded, DNA products and all that. So this is a very, very dreaded disease. Patients having limited lifespan. The entire lifespan is dependent upon control of upper airway infection. The moment upper airway infection goes uncontrolled, the lower airway infection sets in, and that is deadly. The cultures have shown the same bacteria in the upper and lower airway every time when you get done. Even in the post-transplant setting, even a single upper airway infection can lead to a mortality in these patients. So these are young, very difficult to treat patients, and there is no other way than to do all this for these patients. Otherwise, the lifespan is limited. So this is cystic fibrosis. We have to be very careful about the management of this disease, which presents in young children. Any young child presenting with bilateral polyposis should be considered cystic fibrosis until proved otherwise. This is such a common presentation as bilateral polyposis in youngest of the children. So this is how this disease present, and this is how we have to be very suspicious about the diagnosis of this problem. Otherwise, if you overlook, can be deadly to the patient. Next endotype is the pediatric rhinosinusitis. Pediatric rhinosinusitis, unlike the adult rhinosinusitis, has different features. It is more complex than adult sinusitis. It is more different than adult sinusitis for reasons. Adult sinusitis is mostly eosinophilic. You have seen many endotypes driven by the eosinophilic mechanism and more difficult, requiring biological therapy and all that in difficult situation. Pediatric is mostly neutrophilic dependent with abundance of lymphocytes. It is not predominantly eosinophilic disease. The problem, the complexity increases because of other associated problems in children. Children are more often allergic, more often immunocompromised, more often present with different, overlapping symptoms. So their diagnosis is many a times very, very difficult. And children, their immune system is much deficient as compared to the adults. So all these problems add on to the complexity of diagnosis as well as overall management of pediatric rhinosinusitis. Pediatric sinusitis never take lightly. They are most difficult patient, and many a times, in spite of all possible treatment, they are difficult to treat. In spite of not being an eosinophilic disease, and many a times this sinusitis component is overlooked. I'll show you some of the CT scans. Overlooked, the reason being, we generally don't tend to get CT scan done in pediatric patients. They present with a non-specific problems like upper airway symptoms, any allergic or whatever symptoms, but they don't present with a classical triad of CRS symptoms. That's why we don't get a CT scan done, and they remain underdiagnosed. Most of the time, they are being treated on the line of URI, LRI, adenoids, and on other things, on immunity and other things, and the sinusitis part remains underdiagnosed. So, pediatric sinusitis, once it is diagnosed, their management is, as I said, is very complex. It's a neutrophilic driven disease. Most of the time, you have to treat the infection. It is predominantly neutrophilic, requiring more and more, besides the saline irrigation, allergic treatment. As most of the time, they are allergic, these children. Most of the time, it is the culture-directed antibiotic, which is the mainstay of medical treatment. And since you tend to avoid surgeries most of the time in children because of their complexity, you tend to, you are more and more inclined towards the massive medical treatment to avoid surgery, and many a times you need to give culture-directed, even IV antibiotics, and more immunomodulators like pediatric. I said we give in almost all pediatric patients to modulate the immune system to improve the overall immunity in these patients to avoid surgical treatment. But once it comes to surgery, once it comes to surgery, we tend to avoid the sinus surgery in pediatric patient for the reasons. There are many reasons to avoid, pediatric sinus surgery. There are lots of challenges as compared to the adults, because first of all, in spite of, by all means, the diagnosis is still under question. And there are lots of other systemic diseases also associated with it. It's not a single disease, the sinusitis like adult, where you can treat. And once it comes to sinus surgery, their anatomy is challenging. They are, the critical structures are in vicinity, the orbit, skull base, they are in close proximity. The spaces are narrow. Even if you operate in the narrow spaces, the chances of giving synechia are more. And these patients, the success of sinus surgery, so in like any other sinus surgery, the success depends upon the post-operative irrigation. And in children, which is very difficult, as you can't expect the children to cooperate in the same manner like adults for the post-operative irrigations. So in children, the outcome of sinus surgery as compared to adults are poor, and we have to be very much aware of this fact that in children, chances of overall outcome are poor. Yeah. So when you take up the sinus surgery in children, you have to be very much aware of all these difficulties and should include in the counseling of all these patients, because you can't expect that kind of compliance from these patients. So once it comes to surgery, in spite of all maximal medical management, in spite of all immunomodulatory, allergic, infection, all treatment, if the sinusitis, pediatric sinusitis doesn't improve, the role comes of surgery. And once it comes to surgery, the first surgery which should be undertaken is the adenoidectomy. There are reasons to believe this fact. Adenoids in the children harbors biofilms. The recurrent infection in the in this upper airway in the children leads to biofilm formations in the adenoid. The adenoid may not enlarge, but they develop biofilms and they release infective bacteria, because the same bacteria have been cultured every time you take from the adenoid or from the sinuses, the same bacteria which are responsible for recurrent sinusitis. So adenoidectomy is the cure for these patients many a time without doing a sinus surgery. So once it comes to maximal medical treatment, which is over, once it comes to surgery, the first line of surgery is the adenoidectomy. And if there is some collection in the maxillary, some other sinus, you do the sinus was or middle meatal antrostomy or whatever. Treat allergy. Balloon sinuplasty, we don't believe, because it doesn't treat the pathophysiology of allergy, but in children, you can take up for a limited sinus involvement as it minimizes trauma to the sinuses, as the children are not going to do any douching in the post-op. You can consider for limited maxillary sinus work in those situations. Otherwise, the FES is the answer for these problems. So adenoids are the one need to be treated first before taking up for the sinus surgery. Direct sinus surgery is generally avoided in the children, not indicated unless you have some indication. So pediatric sinus surgery is when it is indicated. Like I said, once it fails or adenoidectomy fails, even after the adenoidectomy, if the condition doesn't improve, the sinusitis persists, then you need to take up the sinus surgery. Otherwise, bypassing the medical treatment and the definitive sinus surgery from the beginning is indicated in allergic fungal sinusitis, which is predominant in the young children. Cystic fibrosis, like we discussed. If you have impending complications, most of the orbital complications happen to occur in pediatric sinusitis. Most of the orbital cellulitis, abscess, all orbital complications most likely happen to occur in pediatric sinusitis, and those are the indication for sinus surgery, irrespective of the underlying pathology and the intracoinal polyp. So these are the situations where pediatric sinus surgery has to be undertaken, irrespective of, by all odds, you have to undertake this sinus surgery besides the fail medical treatment and adenoidectomy. So we have to be very clear about the management of pediatric patients, as these are always complex patients. This is the clip to show you something about the pediatric adenoidectomy. Our proposition of adenoidectomy to these patients. Okay. This adenoidectomy, the biggest indication for adenoidectomy is obstruction. Large adenoids are the biggest, indication for the adenoidectomy. But believe me, in our practice, I tell you honestly, most of the adenoidectomy are done in not enlarged adenoids, you can say. Obstruction to me is a lesser indication as compared to non-obstructive indication for adenoidectomy. There are two major non-obstructive indications for adenoidectomy. One is the CRS. Pediatric CRS, the adenoid may not be enlarged to the extent that blocking the nasopharynx, yet you need adenoidectomy to remove the biofilms from the adenoids to, cure the CRS. Now, the other one is the pediatric ear problems, recurrent OME, recurrent otological disorder requiring adenoid, which becomes the source of problem to the eustachian tube malfunction and other otological disorder. And those both the times the adenoids are not enlarged. So enlarged adenoid is not always the indication. But once it comes to adenoidectomy, it has to be comprehensive. This is pure lymphoid tissue. It is not a tumor which is going to come back. Many times you hear the recurrence of the adenoid. The adenoid is not a tumor which can recur. It is a lymphoid tissue which enlarges in response to allergy and infection. The treatment of the adenoid should be comprehensive. Adenoidectomy is a part of treatment. It's not everything that you do adenoidectomy and forget about it. Adenoid treatment requires a concomitant treatment of allergy and whatever immunity and other disorders. If those are not treated, they can regrow. It is lymphoid tissue which can regrow. So this almost always requires an allergy and immunity treatment. But once it comes to adenoidectomy, it has to be comprehensive. And see, we use the cobbletter and microdebrider both together. The first stage, what we have seen just now was debulking by the microdebrider. This is the second phase wherein, the microdebrider, which is being used from the oral cavity side. The red 60 blade, the blunt edge facing behind the cutting edge anteriorly, wherein the entire adenoid tissue being lifted off the perimysium behind, protecting the perimysium. In spite of the little bit oozing going on, which is acceptable, but it's very important to prevent the underlying perimysium damage and the muscle damage. See this, the perimysium is one which protects muscle. If you injure the muscle, that's a disaster which invites lots of problems. All the problems of adenoidectomy related to the regurgitation, nasal twang, all those problem, infection and all those happen to occur when the underlying muscle is injured. If I use the cobbletter, which can give a bloodless field, but this is inevitable damage to the underlying perimysium and muscle. You cannot protect anything, and that is something undesirable. So at this step, use this microdebrider, not the cobbletter. Cobbletter can be used at the end if there is any bleeding or bleeding point at the minimum points rather than everything with the. This is the third step where see this laterally hypertrophic adenoids behind the eustachian tube. These are the important source of problems to the ear. In most of the otologic problems, these are the adenoids responsible for the eustachian tube dysfunction and further inflammatory access to the ear. And these, see this, you press on the perimysium behind and push your debrider, and keeping the cutting edge under vision behind the eustachian tube, you can completely remove the laterally hypertrophic adenoid without damaging under vision, without damaging the eustachian tube. So see, there's a kind of adenoidectomy. Quickly, there's a comprehensive adenoidectomy, preserving the underlying muscle, perimysium, eustachian tube around with minimal use of cautery or cobbletter with the microdebrider, accepting little bit of the oozing in this patient to protect everything. So adenoidectomy is a, primary, once it comes to surgery, adenoidectomy is the first surgery for pediatric rhinosinusitis. And if it fails, then you have to think of, proper comprehensive sinus surgery in these patients, which is otherwise we are trying to avoid that for the reasons I mentioned. These children are never going to cooperate in the post-operative period for any douching or any sort of introduction of topical steroid or antibiotic inside the nasal cavity. So, having discussed everything, the biggest question is when to think of surgery, what is the end point of medical treatment. So again, the same question exists, and here brings our SNOT 22 scoring as the main. I told you that is a patient-centered decision making. There's a shared decision making between the patient and the doctor, that in spite of the best given medical treatment, your symptoms are not coming under control, disease is persisting, and you need to take a call of sinus surgery. And this note 22 prevents you from getting into all problem as the patient is sharing in the decision making process. That is most important. So for by and large, the limit of the medical treatment for the this disease for the polypoidal and non-polypoidal for 8 to 12 weeks for topical treatment, for the topical steroid for the polypoidal, and macrolides and other antibiotics for the non-polypoidal, and if still the disease persists, you have to take a call for sinus surgery. So that's the end point of the treatment, considering 8 weeks, sometimes 10 weeks as the end point. And if you still your symptom persists, your disease persists, you have to take a call for surgery. Except there are certain indications for direct endoscopic sinus surgery. These indications which I'm bringing forward are those where there is no role of medical treatment. The moment you see the case today, you can operate tomorrow, kind of a situation. And these are the direct indication of the FES cases when the patient present with impending complications. Patient many a times, like we have a case I told you about, the AFRS case from day before, presented with a started vision loss. And those are the impending cases where you don't need to wait for the medical treatment to come in effect, and rather treating and preventing for complications. Fungus is a pure surgical entity. Fungus means you have to remove it. No drug is going to, be effective on any non-invasive fungus. Fungus sometimes, like in AFRS, fungus acts as an antigen. Even in non-AFRS fungal balls, you have to remove the fungus. That's the only answer to the fungus. There is no medical treatment for the fungal disease. By and large, allergic fungal sinusitis, which is odontogenic, no medical treatment. Now, the offending cause is, dental pathology. You have to treat the sinuses as well, the dental pathology, both, without waiting, unnecessarily wasting time for the medical treatment. Mucoceles are pure surgical entity because of the obstruction of the sinus drainage without any inflammation inside. There is nothing or no inflammation like sinus disease or inflammatory process happens in CRS. So mucoceles are non-anatomical variant. This is very important. Sometimes you have to take a call early without wasting time on other things. Like many a time we get a patient with concha bullosa or some anatomical abnormality predisposing to sinusitis. Patient coming for the presentation with the sinusitis, of course, you can, resolve the problem, acute problem with the antibiotic and steroid, but it is something when there is a offending anatomical abnormality, it is likely to come back. Patient coming back with the same problem, you can treat with the medical treatment again and again. But once there is offending, reason behind it, anatomical variant, which is predisposing, it is better to, treat such patient. And those are good surgical candidate to give you cure. This is gray area, you can say polyps. Any polyp patient, see, again, you have to take a call when to operate or where to operate or not. Polyp means this is a high-end inflammatory disorder. The inflammatory spectrum is too much, particularly grade 2-3 polyp. Grade 2-3 polyp means polyp occupying the entire middle meatus or polyps extending to fill up the sinus cavity to give nasal obstruction. These are the kind of polyp. By means of your medical treatment means irrigation, doxycycline, topical steroid, you can control the symptoms to some extent for time, but that is not going to give cure, in hearts and hearts. So massive polyposis, will require surgery at the end of the day. Now you have to take a call according to your, understanding with the patient for the surgery now or later continuing with the medical treatment. Ultimately, they will require surgery. So significant polyposis is a gray zone where you can take a call for the early surgery also, because these are the surgical candidates. Ultimately, their disease is not going to go off with the medical treatment only. And these are the classic patients where you can take a call for early surgery also. And this is very, very important. And to us also, and in the Western literature, one of the biggest indication for the sinus surgery. For us also, for many other reasons. Patient, even with a significant allergy with minimal sinus disease, patient with sinus disease requiring oral steroids again and again to control their symptom. Many patients with massive allergy or massive, with minimal sinusitis or minimal sinusitis on scan, but it doesn't resolve without taking steroids. So patients requiring oral steroids again and again is the indication for sinus surgery to prevent the need of oral steroid in the future. Now, after the surgery, once you open up the sinuses, you give the ability for the topicals to go inside, penetrate inside, and avoid the need of oral steroid. So in our practice now, this is the biggest indication for the sinus surgery. Any patient requiring oral steroid again in the 3 months time has an inflammatory spectrum which requires a sinus surgery for the topicals to access inside and avoiding the need for oral surgery. So any patient requiring twice at least oral steroid to control their symptom in 3 months is the indication for the sinus surgery. At least for future, you can avoid the need of oral steroids by means of opening the sinuses and allowing the steroids to penetrate deep into the sinus. Because even the topical steroid in a minimal concentration, what we use the budesonide, 0.5 milligram a day, minimal concentration, up to 5% of this topical steroid is retained in the sinuses for some times unless it is expelled by the mucociliary activity, and that works on the mucosa with minimal systemic absorption without giving any side effect to work as an oral steroid without the need of oral steroid. So that is one of the biggest indication for the need of sinus surgery in these patients, for patient requiring repeated oral steroids to control their symptoms. So this is about decision making in sinus surgery. Before we start our live session, we can take questions now. We'll discuss the surgical and fine details later. Just I'll put forth some of the radiological important things which are important from the surgical perspective. What all to be seen. I'm not going to be going in the details of the radiological anatomy, but certain things which has an impact, how the radiology can influence a good outcome in those patients. Any questions meantime? Yes, please. Significance of? Yeah. W with polyp, S without polyp. It is considered like that. It has been used like before, since before, like this, what I mean.
Sir, one more question. Excuse me,
Yes.
sir. Excuse me. There is one more question.
Yes, yes, please.
I have a patient who is allergic to milk protein. He's just a 3-year-old boy. And his father is a urologist, and he says as soon as he takes some milk, he's a known patient of allergic rhinitis. His father is also having allergic rhinitis. Now, how to proceed for this patient?
Allergy requires immunotherapy. Allergy is, there is no definitive treatment for the allergy except immunotherapy.
Hello, sir. Dr. Stephen here. I
Sir,
was talking to Dr. Mojinder. Past 2-3 years, he was talking about sensitivity of the nose and provided all post-op polyp or allergic rhinitis, you go and do a videoneurectomy. So I've been doing with a very successful rate. And in this talk, I think is not mentioned.
yes.
So
I'll
what
show
is the-
in one of the case a more, rather than videoneurectomy, a more endpoint approach is the posterior nasal neurectomy.
Okay.
That can be used as an adjuvant therapy for such patients, not as a primary therapy. So like all sinus patients who are concomitantly allergic also, simultaneously we do a posterior nasal neurectomy. Posterior nasal, why videoneurectomy? Why posterior nasal neurectomy? Why this change? See, the postganglionic fibers to the nasal glands or the inferior turbinate glands or all this come through the median nerve. How come? The greater superficial petrosal nerve, which is a branch of facial nerve, it forms the medial nerve in the median canal by joining the deep petrosal nerve. This medial nerve come to the greater sphenopalatine, sphenopalatine foramen region, this pterygopalatine fossa, and joins the ganglion. From the ganglion, the postganglionic fibers arise, which supply the nasal and palatine glands. From ganglion, the fiber go to the eye also, lacrimal fibers. Now, before going to the ganglion, if you transect the median nerve, you sacrifice the lacrimal fibers also, which can lead to dry eye. So, the more focused treatment is to do a posterior neurectomy. The postganglionic fibers emerging after the sphenopalatine ganglion, they come out of this sphenopalatine foramen and the perpendicular plate of the palatine bone into the nasal cavity. And that is the area where these filaments enter into the nasal cavity, you can sacrifice. You apply your cobbleter to that region and the fibers are automatically gone. So simple application of the cobbleter in that region through which these fibers come out. I will show during live surgery. That region is between the posterior part of the inferior turbinate and the middle turbinate. From region of the sphenopalatine foramen, these fibers traverse to the inferior turbinate. That area, those fibers travel in the mucosa. We don't need to look for those fibers. You don't need to do any dissection. Just ablate that mucosa, automatically, damages those fibers. So that is posterior nasal neurectomy. That can be used in adjuvant therapy to the allergic rhinitis patients also. Patients having concomitant allergies, all these CRS patients. So it doesn't need anything additional. You just need to cobblate that area. And it works on glandular activity. It works on glandular hypertrophy of the inferior turbinate. It works on neural allergic response, giving the symptoms of congestion and blockage and all that of allergic rhinitis selectively, not everything. It's not a, allergic rhinitis is a medical disease, but all these symptoms can be taken care of by this selectively.
Hello, sir.
No. Aspirin exaggerated respiratory disease is not in patient taking aspirin. It's a disease in those patients, those people who are allergic to aspirin. So we are giving desensitization by means of offering aspirin. We are desensitizing. Those are the patients who are allergic to aspirin. And because of being allergic to aspirin, the COX-1 pathway is inhibited. A leukotriene pathway is activated. So in order to activate the COX-1 pathway, you have to desensitize. You have to start aspirin. These are not patients who are on aspirin. If the patient is taking aspirin, this cannot happen.
Hello.
This cannot happen. We're already protected from this.
Sir, hello, sir.
Yes,
One more question, sir.
please.
Sir, regarding the odontogenic sinusitis, you told that treatment phase plus removal of the dental treatment. So instead of the phase, if we do enter into the maxillary antrum through the sublabial route and do a middle metal antrostomy, will it help?
To the natural maxillary ostium.
We are doing the middle metal antrostomy and we are treating because the entry during the odontogenic sinusitis, the main pathology lies in the root of the teeth
Yes.
or
Yes.
apices. So that area to reach with the endoscope will be a quite difficult area.
That is not our domain. We are treating the sinusitis part. The dental pathology has to be treated by dentist. For sinusitis part, you have to open up the natural ostium of the maxillary sinus and remove the disease. And simultaneously, the dentist will take care of the dental part.
One more question regarding that aspirins thing. Aspirin is we use the aspirin most commonly for the cardiovascular disorder nowadays. So the AERD group of young patient, they are not taking aspirin or anything, no?
They are not taking aspirin. I am not saying they are taking aspirin. This is a group of patients who are sensitive to aspirin. Like suppose you are allergic to aspirin. Like any other drug, if you are allergic to aspirin, then can develop this kind of pathology. So if you have CRS, if you have polyps, if you have asthma, if you are allergic to aspirin, then can precipitate this AERD. Not in the regular patient, everybody.
Sir.
Yes, so CRS patients having NSAID sensitivity are the patients who can develop AERD. Yes.
Sir, kindly elaborate on the histopathological findings.
Histopathology.
Yeah.
See, histopathology, what you look for the parameters for the recalcitrant disease, refractory disease, and the two important parameters for the refractory disease which guides you for the further aggressive long-term treatment. One is the mucosal eosinophilia. Your pathologist can easily tell you per high power field how many eosinophils are there. And the thickening of the subepithelial region. Thickening of the subepithelial region dictates long-term, ongoing inflammation, severe inflammation. And these two things direct you for a long-term aggressive treatment. If you overlook, the patient is going to come back with a, recurrence. So this is something you have to be vigilant about it. So if they don't have CRS, if they're allergic, this nasal blockage is classically treated by posterior nasal neurectomy. That's why I told you that adjuvant therapy is basically to control the nasal glands. Turbinate is a vascular space. Inferior turbinate is a vascular stroma and lots of goblet cells and glands. And those are controlled by the posterior nasal now. So those are the patients who are likely to be benefited by the posterior nasal neurectomy.
Sir, here. Sir, you told about this neurectomy, posterior nasal nerve. Sir, we have been doing this after, in some of our patient after FES. Response was good. But sir, I want to ask about the procedure, the way we do it. So sir, we have been raising the flap, identifying the nerves, and then usually cutting. So
See, there is no point in doing that exercise.
yeah,
We know, we have done several times these cadaveric studies. How do these nerves come out of the pterygopalatine fossa?
right.
There are two pathways through which these nerves come out.
Yes.
One is through the sphenopalatine foramen, some of the branches along the sphenopalatine artery,
Right.
and some of the nerve filaments through the perforation in the perpendicular plate of the palatine bone.
Right.
Now, if you are elevating the flap and identifying, you cannot identify each and every nerve filament.
Right.
So that 1 centimeter area you have to coagulate, assuming the entire nerves coming through that area.
Okay. Sir.
So once you ablate with the coagulator, the nerve fibers and all those are destroyed. You don't need to identify and pick and choose every nerve fiber to treat.
Sir, one more query. Sir, in this coagulation method, is there any chance that these nerves again regain their
Yes, that can happen. Even after the transection, the regeneration can happen, but it is unlikely. Once you destroy the length of the nerve,
yes,
it is unlikely.
Yes, sir. I have seen, sir, once they raise the flap, they even put something between so that these nerves do not again like.
Yeah, I know. You raise the flap, you see some of the filaments coming.
Right, sir.
But still, you cannot count them.
Yes, sir.
You have to entirely, ablate that area completely to remove all the fibers, all the supply which is coming. And that is very simple. Why to raise the flap and do any exercise?
It will take extra time.
I will show you.
Yes.
In half a minute, you can ablate the entire thing.
Okay, sir. Thank you.
Hi, sir. Good morning
Yes,
to
sir.
you. Sir, my question is, you were talking regarding biofilms on adenoids. Could you just elaborate? It will really help us.
So, yes. So that is very important. That's how the concept of adenoidectomy has come in to treat the pediatric FES. See, normally what happens? Adenoid acts as a part of immune system. Whatever challenges we are facing, ultimately all those environmental challenges, microbes, allergens are expelled in the nasopharynx. And adenoid is composed of B cells, basically lymphocytes. It is stimulated, IgA is secreted, and to combat all those challenges and get hypertrophied. So adenoid hypertrophy has crypts which can harbor the biofilms because of the repeated infections. And these biofilms keep on releasing the bacteria to give persistent sinusitis. And it has been proven the same biofilm bacteria found in the sinuses of the children. You remove the biofilm, remove the adenoid, the sinusitis resolves. That's how the concept of adenoidectomy has come in for the treatment of sinusitis in pediatric patients. And it is most effective in children below 6-7 years because the adenoids are more prominent, giving additional blockage. After the 6-7 years, the adenoid side is, the progress of the adenoid is reduced and the size of the nasopharynx increases. So the adenoids are less responsible for biofilms after that age. So this adenoidectomy is more effective in young children for the pediatric sinusitis. I will show you one of the, CT scan in a recent patient. Say this. Say this. This is a probably 4-year-old child. See this massive sinusitis. Massive sinusitis. How can you treat? How can you do sinus surgery in such a young child with such narrow spaces? You have to do all possible means of treatment. You have to try to avoid sinus surgery. But operating on such a young child and expecting post-operative douching treatment is not practical, and chances of giving complications are more. And these children, see this? See the adenoids. Look at the adenoids. Adenoids are not very enlarged, but are responsible to give sinusitis because of the biofilms. It is not the obstruction of the adenoid, the volume of the adenoid, which is responsible to give sinusitis. It is the biofilms which are responsible for giving sinusitis in children. So young children, we should not overlook. Generally, what happens, this remains overlooked because in young children, we rarely get CT scan done. You have done adenoidectomy, child is coming back with the same symptom, the nose is blocked, the same, congestion, same sneezing, same, watering, everything is continuing because the sinus is not scanned and the pediatric sinusitis is overlooked. This is one of the endotype which most often remains overlooked looking at the pediatric age of the patient.
Sir, in this
Yes.
patient,
Sir, do you do eustachian tube dilatation in any of your cases?
Pardon?
Eustachian tube dilatation nowadays, eustachian tube dilatation.
Eustachian tube dilatation. See this another patient. This is another 3-year-old patient. See this. Look at the kind of sinusitis. Now this patient we treated with a adenoidectomy and maxillary sinus washout, antral washout, because other sinuses are not so bad. And this was pure purulence in the maxillary sinus. 3-year-old child. So this was treated along with adenoidectomy, this antral washout, which gave us a material for the culture sensitivity also. And these are classic. This patient is doing well. So you have to choose patient. You have to get CT scan done in the deserving pediatric patient, which are not getting, improvement with the simple medical treatment. You have to be very, very suspicious in pediatric patient because they are immunodeficiency is quite prevalent in pediatric age group. Allergy is quite prevalent. Recurrent LRTI, URTI are more prevalent in pediatric age group. And the sinusitis is overlooked, and that's why they don't get cured. The second part of the question was?
So in cases of patients...
Post-op pictures of this patient after performing.
Most of it didn't get a CT scan done. Yes, madam?
So in some cases where the patients have chronic rhinosinusitis, have adenoids, do you do eustachian tube dilatation?
Yeah, eustachian tube problems are very common. See, we never done eustachian tube dilatation. That's a mechanical dilatation of the eustachian tube. What happens, how the eustachian tube is affected in these children or in all these patients with CRS and the ear problem. See, the mucosa of the paranasal sinus and nasal cavity, eustachian tube and middle ear is same. The same inflammatory process which has started in nose and paranasal sinuses extend to involve the eustachian tube and ear. The inflammation in the eustachian tube mucosa cannot be treated mechanically with a dilatation. This is a joke. So that dilatation is required for other regions, all fibrotic, other blocked eustachian tubes, for long-standing regions, other regions. For such regions, because of the CRS, it is the inflammatory process which is extended to involve. It's a medical disease which is involved the same mucosa lining the eustachian tube. What the dilatation is going to do in these patients? There is no question of any, thinking of dilatation for these patients. Yeah. Yes. See, removal of the turbinate is always a matter of debate. Removal doesn't mean complete removal. For that matter, nobody removes the turbinate completely. Partial removal is indicated. Like for us, I'll show you in a couple of cases in the live surgery. Middle turbinate has to be treated differently in inferior turbinate. Both are different tissues altogether. Inferior turbinate has a different role of humidification and like AC for the nose. Inferior turbinate is like AC. And it has vascular stroma with a lot of glandular tissue which is acting as a humidifier. And this turbinate hypertrophy is of two types. One is bony hypertrophy, one is glandular hypertrophy. For bony hypertrophy, we do a partial resection. Partial resection means, I'll show in one of the case, with leaving minimal raw area, most of the turbinate is there. Only the part which is hypertrophic, blocking the airway, has to be excised without giving any problem. Not complete turbinectomy. Complete turbinectomy is something which is going to give symptoms to the patient in many ways, in terms of dryness, in terms of, a lack of temperature control and so many other issues. In middle, for the glandular hypertrophy, we never do a partial turbinectomy, we do a posterior nasal neurectomy, which takes care of that. For middle turbinate is a different tissue, that is not erectile tissue like inferior turbinate. And indications of middle turbinectomy are different in CRS patient. We have some patient where I am going to show you there are many ways to deal with the turbinate. The concept of partial turbinate resection has come up in a big way and it is beneficial in certain situations. Complete turbinectomy is never done as part of the upper part of the turbinate, is always left for identification of the turbinate as well as skull base and frontal ostium as a something to keep you oriented all the time. But the inferior part of the turbinate sometimes is a problem and has to be, resected, planned resection. In spite of that, the turbinate is not, mobile or something. It has to be resected for two reasons for us. One is when you have a disease medial to the middle turbinate. You have sometimes massive polyposis medial to the middle turbinate, which is, obstructed the path and the turbinate itself becomes an obstruction. In those cases, for our topical to be introduced later on, we do a partial turbinectomy and remove those polyps from that region, only in the lower part. And second, in all olfactory patients who present with a significant olfactory loss and disease medial to the middle turbinate, for your topicals to go effectively to the olfactory region, you have to remove partly the lower part of the turbinate. So these are the two indications for partial planned turbinate resection. We have a case where we have polyps medial to the turbinate. If you don't resect the turbinate, you can't clear the disease, you can't ensure the topicals going there, and you have to do a partial resection. And now in a massive eosinophilic disease, which requires long-term steroids, it is always advisable, whether required or not, to do a partial resection for your steroid to reach effectively. So that's a planned partial resection, which is advantageous.
Sir, what are the pre-op preparation for doing face surgery? What are the medications, and is there any role of using intravenous transamic acid for control of bleed?
I can't hear. There is so much of echoing properly.
What is your protocol for pre-op preparation before for face surgery?
Application of?
Pre-op preparation.
Pre-op preparation?
Yes, sir.
So that we'll discuss in the case, but yes, to answer this, pre-op preparation is required to reduce the inflammation, to reduce the overall bleeding. And that is achieved by various means. Like all polypoidal disease patients have a high inflammatory load. Their mucosa is highly inflammatory, highly vascular, and to prevent the bleeding, too much of bleeding, you have to start steroids 2 days before. That is pre-operative preparation. Same thing has to be done intraoperatively to decongest the vessels, to facilitate the venous drainage, to reduce the cardiac output. So many things are to be done together. We'll discuss in OT to reduce the inflammation, to reduce the bleeding. Because the single most factor responsible for the complication is the lack of orientation. If there is too much of bleeding, there will be lack of identification of the landmarks and chances of complications are high. Because this is the surgery of landmarks. Even a some millimeter disorientation can lead to disaster. So you have to be very careful. The field should be very, very good to keep your every step under vision, completely oriented. Can you take mic? What? For the face. So that is a decision making you have to share with the patient. Because your question is right, that's what we are discussing. As a safety profile, we have only thing pre-operatively as a weapon. Biggest weapon is the topical steroid. Now, if your inflammatory load is too much to be taken by topical steroid, you have to take a call for surgery. So, or you can give in between course of systemic steroid to reduce the inflammation. Now, if the need of the systemic steroid is again and again, is the indication for surgery. So somewhere you have to define that your inflammatory load is too much, which is not being taken by the medical treatment, and the surgery the needs to so as to avoid the oral steroid again and again.
Sir, sometimes the symptoms disappear, sir, after using steroids. But after we stop the steroids, again the symptoms comes back.
Yes.
So, sir,
So the inflammation is too much, and that is the indication for surgery. That's why I said, leaving aside everything, any patient requiring oral steroid to control their symptom twice in 3 months is a strong indication for surgery. There is no point in giving steroids again and again. Those are the candidates who have high inflammatory profile. Operate them. The role of surgery is to give ability for the topical steroid to penetrate.
sir, and the dose of clarithromycin, and for how long we have to use clarithromycin in CRS?
Dose of
Clarithromycin.
Clarithromycin. Yeah, somebody had asked me there also. Clarithromycin to be used not as an antibiotic. It is to be used as an immunomodulator. So low doses of clarithromycin for its immunomodulatory action on the entire inflammatory pathway has to be given for long term. Mostly we use clarithromycin, but the safety profile of clarithromycin is sometimes not permitting for many of the patients, because clarithromycin is digested in the liver by the cytochrome P450 pathway. And there are a lot of drug interaction with a lot of drugs. So in elderly patient, it doesn't allow, or physician doesn't allow the clarithromycin to be used. For them, the azithromycin is very safe. It is not metabolized by the same P450 pathway. So azithromycin has the least drug interaction. But the most suited is the clarithromycin, overall as a safety profile and efficacy and all that. But certain times azithromycin. When azithromycin is given, see, for these macrolides, these are the only drugs which have, as compared to the serum, they have more than 100 times tissue concentration. That's why long-term low-dose azithromycin accumulate in the tissues. The clarithromycin macrolides accumulate in tissues and exert a lot of these immunomodulatory effects. Clarithromycin is to be given in 250 milligram once a day for minimum 4 months, sometimes 6 months, whatever. Azithromycin is to be given 250 milligram 3 times in a week. Something like that. And so according to the situation, you can choose any out of them.
So you said that you wait for 8 weeks while giving topical corticosteroids. But the European position paper on this is slightly differing. That
2020.
Yes.
There are two position papers,
Yes, one is
2012, 2000, EPOS 20.
Yes, 20. So this is according to 20.
See, I tell you, the EPOS 12 was, EPOS 12 mentions UCLA guidelines.
Yes, yes.
And according to that, you can give for 8 weeks.
Yes.
The EPOS 20 European position paper has different opinion. So there is no time limit now. You have to involve the patient in decision making. If the patient is happy with taking with the oral topical steroid without any symptoms, what is the, why to hurry for the surgery?
Yes, sir.
So there is no time limit like that. That is our goal. If the inflammatory profile is not that severe and patient is happy controlling symptoms with a topical steroid only, what is the need for sinus surgery? Why to rush for sinus surgery? Yes, if he needs oral steroid again or not able to control his symptoms on topical, then you have to think of it. So there is no as such time limits.
Sir, is there any role of intravenous transgenic acid before surgery or
what
during surgery? Tranexamic acid.
What? Tranexamic acid for the control of bleeding.
Yes, sir.
Yeah, lots of paper advising after induction a dose of tranexamic acid, 1 gram tranexamic acid to reduce the bleeding. It is actually an antifibrinolytic agent. It is believed to, reduce the bleeding. It reduces, obviously, being antifibrinolytic, it reduces bleeding for many other, surgeries. But in sinus surgery, the source of bleeding is capillaries. And you get the same field by means of preoperative and intraoperative preparation without any additional need of such systemic therapies. It has been, studies quite extensively when the patient was given tranexamic acid and not given tranexamic acid along with the full preparation with hardly any difference. Yes, it has a role. I don't doubt about it. But the question is the need. Why to give any additional systemic therapy once you get the same additional field with this? Yes, it is more effective in skull-based situations when you expect more bleeding or more extensive surgeries, but not in sinus surgery.
Okay, thank you, sir.
So last 15 minutes before we end this session at 1:30, what I was coming to the role of CT scan before we start the surgical session. So quickly in 10 minutes, I'll just touch upon certain issues, how to look at the CT scan, what all we expect from the CT scan. Yes. And what kind of CT scan to be ordered. See, CT scan's role, we discussed the entire session, but hardly anything about the CT scan for the decision making. So CT scan has no role in decision making for surgery or no surgery. Once it comes to surgery, then comes the role of CT scan. Because it gives us three-dimensional anatomy of the region where we are going to operate. And this region is very critical. You see, this region is critical in terms of close proximity to the skull base and the orbit all the way, and lots of neurovascular structures around. So you need to have a full dynamic sub-millimetric CT scan giving us three-dimensional dynamic imaging. If you give me a single plate of CT scan is of no use. That cannot help avoiding complications. That cannot give you complete information. So what CT scan we order, we advise is a 0.5 mm CT scan in DICOM format. And then using this software, you can reconstruct. And that's an amazing teaching tool for your institution, for your own, where you can relate each and every structures 3D from the CT scan. So any structure you can see from this plane, what exactly, how it refers to the other plane, how certain anatomy is best seen on coronal plane, certain anatomy on axial, and certain structures best delineated in the sagittal plane like frontal sinus. So you need a three-dimensional imaging of the entire field in the dynamic format. I will give you certain example why this dynamic format is important. And this is very, very important in the frontal sinus for complete clearance, desired clearance. You know, the biggest problem in the frontal sinus disease, frontal sinus as compared to the sphenoid and other sinus is relatively safe away from the critical structures except medially skull base. Where you stay laterally, you can avoid the skull base injury. But the biggest problem in the frontal sinus is the residual disease and the scarring a surgeon leaves. Frontal sinus has lots of variable cells in the frontal recess, in the frontal drainage pathway. Looking at the CT scan, you need to clear each and every cell and widen the pathway. Otherwise, any kind of scarring or neoasterogenesis or raw area you leave behind or cellular septation you leave behind, demanding a revision surgery is most challenging. Then you need to really go to a more extensive procedure like DRAP or some other procedure later on to tackle those challenging situations. So CT scan gives you a clear concept of the cells in those regions which you need to clear, three-dimensional anatomy. For any structure you can see dynamically rather than a static. For example, this is your uncinate process. If you really want to see where the uncinate is going, see this, how the uncinate is going up, up, up. This is merging with the agar negi here, and inserting on the orbit, giving a medial drainage pathway for the frontal sinus. Uncinate going medially, going to the skull base to the terminate, giving a lateral pathway is a different one. And this is very important to prevent complications at the beginning. So for every structure, it will give you dynamic pathology. You can see axial, coronal, sagittal in all planes. Like for example, this particular patient has an agar negi cell here. See this agar negi? That's the beak. And this is the frontal sinus and this is the drainage pathway. Now this frontal drainage pathway is somewhere between, this is the bulla, suprabullar cell behind, and this agar negi anterior, this in between is the frontal drainage pathway. This is an example. So looking at the cellularity in the frontal recess, you have to tailor your therapy. You'll see in all live surgery cases, every case has a different, some or other different anatomy which has to be picked up by CT scan and accordingly addressed. If I have a agar cell, now I know I have to go behind it and fracture it out anteriorly. I see where my beak is. See, this is a beak and this is the frontal sinus. The obstacle to the frontal sinus is this beak. You're coming with the endoscope 70 degree, you have to go literally far anteriorly and up for the frontal sinus to address. So the configuration of the beak is the one which is the limiting factor to address the deep frontal sinus pathology. Tomorrow, you have a type 4 cell, a big type 4 cell, which requires a draft 2 to address because the cell is rising high up to the height of the frontal sinus. You cannot go beyond that cell to tackle it down. You need a good exposure as requires a draft 2. So lots of draft modifications are, available to address, and CT scan will guide you what kind of treatment is required. This is important for the patient counseling as well. Sometimes you take up the patient for the sinus surgery and ultimately you realize that it will be converted to a draft. And telling patient to convert to a draft, more invasive procedure, which might incur extra cost, extra time, extra lot of things, sometimes it is not, acceptable to the patient. So you have to be, the CT scan is a guiding force in those situations. So in CT scan, you can see each and every anatomy. We'll discuss in detail, not here now, which are, important for the patients in every different, case. Here, I'll give you some examples to simplify and to know that how important a CT scan is. See this. This was the patient. I'm giving some examples of the allergic fungal sinusitis. We have already discussed what is allergic fungal sinusitis. Allergic fungal sinusitis, we have seen where the fungus is an antigen. This particular patient, see this. See where the fungus is. We have a similar patient. This patient presented with blindness. See this. This is the lacerating of the sphenoid. That is the optic nerve. And this is the inflammation which spread to the optic nerve. This can involve the optic nerve by both the means, by pressure or by inflammation, spread of inflammation presented with blindness. And these are the patients who have a best prognosis. CT will tell you the dehiscence of the surrounding structures. For frontal sinus, it will tell you how the frontal sinus, see the disease in the frontal sinus, expanded. Allergic fungal sinusitis expands. See the dura is absent all over. The roof dura is absent and the disease is extending up and up because this material is not able to clear out. It is expanding. More and more eosinophil is around the fungus, and this kind of dehiscence all around the bone, orbit, all around the skull base. So CT will warn you to handle such extensive problems, warn you of bony defects, and a dynamic CT scan will give you a complete three-dimensional picture of all around. You can exactly see where the bony defects are, see the sagittal section, so that you are more careful in those regions. So in allergic fungal sinusitis, most of the time you will find such bone, defects, and you have to be very careful in those situations. Now, see this. This example is a very important example, and this cannot be picked up without a dynamic CT scan. And if you overlook, one cannot do a complete job to clear this pathology. See this patient. See this patient, frontal sinus, unilateral frontal sinus disease. See the value of dynamic imaging. Frontal sinus disease, anteriorly frontal sinus coming behind the beak. All those frontal cells are anteriorly placed, close to the beak. Now I'm going behind, and now a cell appears. Cell appears in the frontal drainage pathway. The frontal sinus drain from behind. So posterior cell looking like a type 4 cell cannot be type 4. And see the location of the cell where the entire frontal sinus is going to drain. Now, how can you identify what kind of cell is this? Reconstruct. Sagittal. See this? Let's pick up the cell in the coronal. This was the cell, and look at the sagittal. Look at the sagittal, this cell. This is the frontobular cell coming from behind. Frontobular cell. See this frontobular cell extending into the frontal sinus, blocking almost completely the frontal drainage pathway from behind. Now, if somebody assumes it as a type 3 cell, where the treatment is to go behind and bring the cell out. If you try to go behind cell, you will breach the skull base. Now with the CT scan, dynamic and three-dimensional, now we know each and every place of each and every septation. Now we know our pathway. This is the narrowed frontal drainage pathway. You need to, go along the beak, you go into the frontal pathway, open up this cell by taking up this septation and flush with the skull base. So this is frontobular cell. This is the cell which is behind, attached to the skull base, and accordingly you have to treat it. Had this been a type 3 cell, type 3 cell would have been attached anteriorly, and then we would have to go behind it and bring it out. So the good dynamic CT scan exactly tell you what kind of a single printout cannot give you this kind of information. And ultimately, what happened, the frontal sinus is already considered a single printout with any kind of these cells, and once you an endoscope, everything looks like frontal sinus. All cells look like frontal sinus, and ultimately end up doing a incomplete job, needing a revision surgery, which is 1,000 times challenging in frontal sinus than a primary surgery. So CT scan can prevent you from such a major problem if you understand those cells very clearly. One of the patient we have kept in the list probably today evening or tomorrow is one of the problems which, if you understand this CT scan, can be tackled so easily, otherwise it is most difficult to treat. Believe me, even the open surgery cannot treat this problem. Let me show you. There's no open surgery can answer this problem except endoscopic with some orbital transposition. Look at this allergic fungal sinusitis. See this frontal recess on this side. This frontal recess is so narrowed, completely blocked, which has blocked the drainage of the frontal sinus into the frontal recess, and the orbital bone is destroyed, and the content is prolapsing into the orbit. Now, how can you address? If you try to address it by the external approach, you cannot communicate with the frontal recess because, see, it is already so narrowed by this bone. This superomedial bone of the orbit is the biggest obstacle. This is the obstacle. See, this has narrowed the drainage pathway. And this has burst lateral to it into the roof of the orbit. Now, how to address? Even if you address by the open approach, you cannot communicate the drainage pathway, and again it is going to come back. It is not the removal of the mucosa which is important. It is the establishment of a drainage pathway to prevent future problems. And in order to deal with these problems, these are the classical cases. I have kept one of the cases in the list which require orbital transposition. Orbital transposition is what? This superomedial wall of the orbit is responsible for narrowing this drainage. And in those situations, you have to remove this superomedial wall. You have to remove this bone, complete bone, separating the periorbita away. Separate the periorbita away, punch out the bone, and widen this drainage pathway into the nasal cavity. That's the answer. That is called orbital transposition laterally. And that's the only answer for such patient. Another example, see this. Because this laterally trapped mucocele, this is a mucocele which is laterally trapped, the same patient. Look at the MRI. See this. This is the frontal sinus disease. That's the frontal sinus disease. This is the bone which has narrowed the pathway, narrowed the drainage pathway. These are the polyp. And see, this lateral sinus is drawn, not draining, leading to a mucocele which is pushing and giving proptosis by means of, taking away the floor roof of the orbit and giving proptosis. Now, for such problems, unless you don't establish this drainage pathway, removal of this mucosal is never going to work. You operate any number of times, it is going to come back. So you need to communicate. You need to communicate this with this drainage pathway to prevent problems in the future. And that is possible only by removing this superior-medial part of the orbital wall. And then you can give a wide drainage pathway to the lateral most part of the frontal sinus. So CT scan or the imaging will guide you exactly that what kind of a surgical treatment is required for particular patients. Accordingly, you can counsel your patient to dictate the kind of particular treatment. Now, another example. Yes, Pawan, please. Yes. See, you're obliterating the lateral part, but still not communicating with the medial part. And you never know where again the mucosa is trapped. Again, the mucosa is trapped because the medial limit is not defined. You only obliterate. Now, medial limit, whatever you left, you're never sure it is going to be aerated. So this is going to come back. So that cannot communicate. You have to ensure each and every bit of mucosa removal until that part which is communicating. If that communicating, that doesn't require a mucosal removal. But the part which you are obliterating has to be completely segregated from the drainage part. That is impossible.
That
to
is
remove
for
each
sure.
and every
That
bit
has to
of
be taken
mucosa.
care of.
And it is going
You
to
have
come
to
back.
even drill. You have to even drill
Whatever.
the bony margins. And then
Question is the
obliterate.
remaining mucosa. Question is remaining mucosa.
Because it might be a good theory, but if you talk about localized mucocele there, which is going superiorly or supralaterally to the orbit, I think orbital transposition for a mucocele, which can
I'll show you again.
I'm not done, boss. To deal with that looks like an overkill to me. So what you can do is
This is simple. We have a case. I'll show you. This is the simplest lifetime answer to it. Without breaching into the orbit, without going into the orbit and establishing natural drainage pathway to the far lateral area. That is completely physiological. See this, what you are saying. If you remove this mucocele only and obliterate it, we have to establish this rest of the drainage pathway. Now, until now, wherever you obliterate, the rest of the pathway should be communicated to the nose. If this end point is not communicated, it is again going to give the same problem. You cannot count each and every mucosa. So the answer has to be physiological to completely communicate forever. And this is orbital transposition. This is the final answer we have done in so many patients, and they do so well. You don't need to go external. You don't need to, be thinking of the revision or need of revision or any problem in the future. Just do and make it physiological once forever. That is the final answer to these patients. Now, what I was saying, this is another problem. See, we have a case also for this large intersinus septal cell. See this. Look at the CT scan. Where is the frontal sinus? This big is the intersinus septal cell. This is the beak. This big is the intersinus septal cell. And these two are the frontal sinuses. Now going behind, see this. Going behind. This is the intersinus septal cell, which has replaced most of the frontal sinus. And these are two small frontal sinuses laterally, which now are communicating to the frontal recess. And this cell is actually communicating to the left side frontal sinus. So intersinus septal cell communicates on either side with one of the frontal sinus. And you need to see on dynamic imaging which side it is connecting, and you remove the party wall and your problem is over. You remove this party wall between the intersinus septal cell and the frontal sinus and the problem is over. And that is so well defined on dynamic imaging. See this, the huge The intersinus septal cell is, 5 times bigger than the frontal sinus, and the frontal sinus is laterally placed. So what kind of cell, whether it is frontobular, type 3, because the frontal sinus cellularity in the frontal drainage pathway is so variable. So it can be best defined on dynamic imaging like this. And this is the way you need to look at the frontal sinus. We will see case by case, every case, what kind of, important finding is there. Accordingly, we will discuss that. Before we leave, any questions, anybody? Because 2 o'clock, we are in half an hour's time, we are starting a surgical session. Yes, sir. Transorbital. That is not transorbital. Yeah. So, yeah. See, you can make ports any, but how will you ensure the drainage? Question is the future drainage. You have done obliterated, you have removed whatever. But how will you ensure the remaining frontal drainage? So answer should be physiological, not removing anything. It has a mucosal, it has a mucosa inside. You have to communicate with the nasal cavity. So this requires orbital. We have a case, we'll show you how this orbital transposition can be done very easily. It's not difficult, but it requires a proper surgery to give a physiological answer. Yes, Shailesh. Yes, please.
Is there any role of combined approach, like endoscopic and external? Or
that's what Pawan was talking.
Yes. So orbital transposition will take care of the farthermost laterally placed mucosals for drainage?
Anything. See, when this sinus surgery was introduced, the earlier concept was if the disease is beyond the mid-orbital plane, laterally, is a contraindication to endoscopic approach. Now in the era, this era, we can reach any pathology. We have done several times, even the disease reaching far laterally, even to the pterion. There are ways to do it. Orbital transposition is the simplest way to reach to the lateral part. If you have to go beyond, you can do a modified hemilothros. Modified hemilothros is what? Do a graft on the same side.
Yeah.
Then a nasal septotomy, and coming from the opposite node with the angled endoscope far laterally to give you access far laterally to the same side. So to reach the far laterally on the same side, you come on the opposite side by a septotomy and draft too. So that gives you, that is modified hemilothros. So there are many ways to go far laterally. There is no contraindication for any lateral most pathology in the frontal sinus for endoscopy.
Yeah, one more situation. If there is a anterior table and a posterior table distortion by the mucosil and the meningeal enhancement, still meningeal enhancement, pachymeningitis of the frontal dura. So still you prefer to do
endoscopic.
Okay.
That is the best answer.
And
Or
how
not
to
only that,
reconstruct the defects, or you
any
just leave it
pathology.
like that?
Any pathology, any even benign tumor, any CSF leak, because it's a matter of exposure which was limiting. Now with the lots of draft and their variations, you can expose to any level.
So is there any need of reconstruction after
No
you do
need.
orbital transposition?
That is the biggest
Or leave it
advantage
the
by
defect like this?
that is the biggest advantage by endoscopy, because you are communicating for the drainage. You don't need any reconstruction. If you are obliterating, if you are doing something non-drainage, then you have to reconstruct. Once you are communicating with the drainage, you don't need any reconstruction.
Thank you.
Hello, sir. Question regarding enteroconal polyp. Enteroconal polyp.
Sir.
In spite of being removal after visualization of cavity with 70-degree scope, still we can find in particular early age group that it recurs.
AC polyp recurrence. Yeah, AC polyp is a different pathology. This is not like these polyps. Their etiology is still, there are so many theories proposed. But the most acceptable is a negative pressure lymphedema theory, because it comes out of the accessory ostium because of the negative pressure in the nose and because of the lymphedema in the base. So AC polyp can recur in spite of the big, middle meatal enterostomy, establishing ventilation drainage, it can come back. So it has been proposed to coagulate the base of the polyp wherever it is attached to prevent future lymphedema. You can take a canine fossa approach secondary to reach out that area, because sometimes the attachment is far lateral, far anteromedial, not accessible by the regular enterostomy. You can take any other approach.
What is the solution used for nasal douching irrigation?
What is?
What are the
Solution?
Yeah, used for.
So we'll discuss that tomorrow in the post-operative part. But yes, once you have asked, we use the budenoside solution, aqueous budenoside, mixed in saline or ringer lactate, and then douched properly in certain positions.
Sir, one question.
Budenoside, which is generally used for nebulization for asthma.
Okay.
Respules.
Respules.
Sir, excuse me, sir, in patients who have allergy, one patient will not develop anything, he will just have plain allergic rhinitis, and another patient will develop bilateral polyps. So how is it decided this patient will go this way and other patient develop polyps?
See that every patient has a different immunity profile. So every allergic patient is not developing sinusitis. Those allergic is a pro-inflammatory stage because the same cytokines are involved. Now, in that pro-inflammatory stage, somebody has a immune dysfunction, sinonasal immune dysfunction will lead to sinusitis. So ultimately, the thing which comes again and again is the immunity. So you have to improve that. And if there is any dysfunction, you have to treat it. Which? Prednisolone. Simple. Though you can use any, all these have relative potency. All are same.